Good morning, and I would like to welcome everyone who is present in the chamber and all those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would like to add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to try and ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep these succinct and concise. However, I will close down the debate to ensure we keep to time if needed, and would ask you indicate early to guarantee your question. As the meeting is being streamed in the usual way, I would like to remind you all that your comments will remain accessible online as the meeting recording remains on the council's website. I'd now like to move into agenda item 1, apologies for absence and replacement members, please, Trina.
Thank you, Chairman. We've received apologies from Councillor Martin, but we have Councillor Stokes here as his replacement. Apologies from Councillor Parkin, Councillor Lucille Higgs, but we have Councillor Jonathan Pestle here as her replacement. Councillor Moira Westerly, and just to let you know, Councillor Westerly has been appointed on here by West Lindsey District Council on Monday, and we've also had an apology from Liz Ball. Oh, and also, sorry, Councillor Sue Woolley, Executive Councillor NHS Liaison, Integrated Care Systems, Registration and Coroners. Thank you, Chairman.
Thank you, Trina. Councillor Cleaver?
Councillor Morgan is on her way. She's been redirected to some strange route with which
Okay,
she's unfamiliar.
not hugely surprised the way it is at the moment. Thank you. And I'd just like to say a special welcome to Councillor Burke, who is our replacement member for City of Lincoln. Welcome back. It's nice to see you. And also thank you, Councillor Pettle and Councillor Stokes, for your attendance today. So we'll now move on to agenda item 2, declarations of members' interest. There's an opportunity for members of the committee to declare any pecuniary or other interest. Do any members have any interest at this point? Councillor Kendrick, please.
Thanks, Chairman. My usual declaration. I'm a partnership governor of LPFT.
Thank you, that's noted. We'll now move on to agenda item 3, the minutes. This is to confirm the minutes of the meeting held on the 17th of April 2024 as a correct record. They are found on pages 3 to 12 of the agenda pack, and as the committee has had the opportunity to read these in advance, I plan on taking these on block. Do I have a proposer? Thank you, Councillor Mackinson-Sanders, and seconded Councillor Scalesi. All those in favour, please show. Thank you. Those against? And abstentions? Thank you. Have you got those, Trina? Yeah, thank you. They're noted. That's the minutes move, thank you. We'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda, and my supplementary announcements were circulated on the 14th of May. Do I have any questions on these, please? No, in which case do I have a proposer that we note these, please? Thank you, Councillor Mackinson-Saunders, seconded Councillor Smith, and all those in favour, please show. Thank you, that's supported. In which case I'll now move on to agenda item 5, the Lincolnshire People's Strategy. This item was circulated as part of the agenda pack on pages 15 to 32. This item provides an update on recruitment and retention in Lincolnshire and sets out the progress made over the last year. I'd now like to welcome our presenters via Teams, Claire Lowe, Senior Responsible Officer for the Lincolnshire NHS People Strategy, and Mark Ratley, Deputy Director for People, Lincolnshire NHS ICB. If I can hand over to you and get you to walk through the report in around about 5 to 10 minutes, and we'll take questions at the end. Thank you.
Thank you, Chair. Good morning, everybody. Thank you for the opportunity and the invitation to offer the committee an overview and an update from the Lincolnshire People Board. Our last presentation, can you believe, was in March 23. Gosh, I can't believe it was over a year ago. But I'd like to summarise some of the highlights within the tabled report, if I may. So our main drivers within the Lincolnshire system continue to be the NHS long-term workforce plan and the Department of Health Social Care paper, which puts a focus and emphasis on the next steps to put people at the heart of our care. Under our attraction, you'll see, members of the committee will see that we've grown our workforce significantly over the last year and since we previously presented. And as a result of obviously growing our workforce, we've actively reduced our vacancy position. And I know that was a concern of some committee members when we spoke to you last year. We do continue to go from strength to strength on our One Workforce brand, which is also supporting our attraction and retention agenda, meaning that lots more of our staff are choosing to stay and remain within the Lincolnshire healthcare system. This is also supported by 4 people promise managers, and I'll explain to you what their priorities are. So they're very much focused on attraction, retention, reward and recognition. And these posts have had a massive impact on us keeping our staff happy and well in the Lincolnshire ICB system. So with regards to the National Staff Survey results, you'll see in the report we've improved on all our domains, including turnover being reduced dramatically and our retention improving. And we've also been accredited for our ability to offer our staff much more flexible working opportunities, which again encourages our staff to stay within the health and care sector. Workforce planning is still key to ensuring we have a future ready workforce, and we are working really closely and continue to work very closely with our local schools, our colleges and our universities. It's very important that we continue to grow our own through our apprenticeship routes at all levels and all skill sets to ensure we have the right people at the right time with the right skills. I just wanted to say thank you for your interest and your time this morning, and I hope that you found that update helpful, and happy to take any questions. I've picked out the points that I thought were most relevant following on from the session that we held in March. Thank you very much, Chair.
Thank you. I've got Councillor Smith first.
Thank you, Chairman. And notwithstanding your first point, with your indulgence, I do have a very brief third point, if I may. I note the vacancy percentage for LPFT stands at just under 12%. What is the national average, as although it's clear substantial improvements have been made to the vacancy rate within LPFT, that is still a significant percentage. Secondly, what proportion of newly recruited staff came from international recruitment versus homegrown recruitment across ULHT, LPFT and LCHS? And is this something that we could, get a breakdown of on a regular updates on? The reason I ask for this, Chairman, is because it's important that we have this information so that we can assure ourselves that the recruitment model that's being used is sustainable, as eventually we are going to hit saturation point from international recruitment, as those countries will need those individuals for their own healthcare systems, and there may be retention issues and wider issues around that. And my third point, Chairman, which as I said is very brief, I note that one of the reasons highlighted for morale and its possibly being low and possibility of people leaving on the exit questionnaire was dealing with management. How common was this theme across exit questionnaires? If it was common, what steps are being taken to rectify that issue? Thank you, Chairman.
Thank you. Can I come back? Thank you. It was Councillor Smith. Thank you. In terms of the LPFT vacancy position, the vacancy position has increased due to national funding that has been allocated to mental health nursing, meaning that the vacancy position has grown due to the allocation of additional funding. So as quick as they can recruit, they get more funding to bring in more nurses. So we're doing lots of active work to support the vacancy position to get that to a stable position. But that is linked to additional funding that's grown the workforce numbers in the Mental Health Trust. So I hope that does answer that question. Excuse me. Really good point, Councillor, in terms of the dynamics of the mix of our international staff versus UK-based or locally grown staff. We are very focused on the sustainability of international staff supporting our vacancy position is not sustainable for future years, and it's really important that we don't become so dependent on our international colleagues that we therefore then end up in a situation where we're back with high vacancy rates. So we're doing lots of work in terms of a 5-year plan on how we reduce our reliance on our international recruits. And this is linked to the work that we're doing with our educational providers in terms of nursing apprenticeships, increasing the numbers on our nursing apprenticeships, how we look at alternative roles like ACPs or nurse consultants to help with the vacancy position. So again, that's linked very much with the local agenda in terms of ensuring we've got local staff to serve the needs of our local population. So we're acutely aware, as much as we value our international staff and they're very much part of our work family, it is important that we don't focus all our reliance on the international staff because it is an ever decreasing pool with lots of competition in terms of resources drawing in on that pool. In terms of exit questionnaires and staff leaving in terms of perhaps a breakdown in relationship with management, I think it's fair to say to the committee there's more work for us to do on this as part of capturing. We have quite a low uptake on exit questionnaires, so we really need to get under the skin of why staff who continue to leave, because although our turnover has reduced, we do still have, of course, have leavers, and really getting under the skin of why staff are choosing to leave. I do believe there is some work to do in terms of culture, in terms of perhaps that breakdown in relationship with managers, but I do believe it's not a huge concern in terms of one of the only reasons why staff are leaving. I think it's one element of staff that perhaps may be leaving for other reasons that aren't being captured. So I would like to offer the committee this morning perhaps some assurance moving forward in terms of a further deep dive on the turnover and the exit questionnaire process. I think we need to do a little bit more on, if I could offer that as a suggestion. Thank you, Councillor.
Thank you, Councillor Smith. You'd like to come back?
Yes, please, Chairman. Thank you very much for that very honest answer. Firstly, if I would very much, Chairman, with your indulgence, I'd very much like for that 5-year plan for us to look at that, and thank you for highlighting that. Very briefly on my first question, it's slightly answered it, but you slightly missed it. The question I was asking really is, in the national context, in terms of vacancy, where is LPFT within that broader picture? And it's actually very good that you highlight actually more funding is being given out, so you're actually having more vacancies in terms of mental health. That's very pleasing to note, and thank you, Chairman, for allowing me to come back.
Okay, Councillor Allen next, please.
Thank you, Chairman. It's a variation on the question that's already been raised by Councillor Smith. The problem that I see, the problem that I have in the report and the presentation is that we talk about actual numbers in some part in terms of the increase, the substantive increase in the actual workforce, and then we talk about percentages in terms of vacancy rates and so on, and it's very difficult to understand what the relationship between those two things are, because we do seem to have got something like about I don't know, getting on for 2,000 maybe from March 22 to current date, extra people in the workforce in Lincolnshire, which is obviously having some effect on the vacancy rate, which has reduced from 12% to something like 6% in some cases. The difficulty I have is, presumably there's a certain percentage of vacancy rate that's fundamentally built into the business plan. There will always be some vacancies within the organisation as people leave, with presumably relatively short notice points. And the business presumably operates, or a business would presumably operate fairly effectively with that built into its business plan. It's just there. It's just a natural product of operating a business with quite a large workforce. What I can't, that's one question to start with. So should we necessarily be worried about a vacancy rate of 6% or whatever it is, if that's the natural figure that's operating within the business and within the healthcare sector? but what I have difficulty understanding, and that's the point that Councillor Smith made, is to a certain extent where these people are coming from, because if these are new people entering the industry, the healthcare industry as a whole, that's fine. Councillor Smith did query whether they're coming from internationally or whether they're homegrown, and that's something I think that's particularly interesting, because I do have reservations about the international stripping of healthcare officials from organisations, homegrown organisations, where they're particularly useful when they are working abroad. Or are they just people moving around the industry within the healthcare sector, either in Lincolnshire or within the NHS as a whole, or the healthcare industry as a whole? Because that is not really resolving the issue to a certain extent if they're just moving around from primary care to secondary care, or from the private sector into the NHS sector, or whatever it is, or just moving within organisations on a promotion basis. I don't think we got enough information here, and the presenter talked about a deep dive. I think the deep dive ought to give us a bit more information in terms of actually trying to understand what the figures are, particularly when we mix up percentages and pure numbers.
Thank you.
Yeah, thank you.
Thank you, Chair. Thank you, Councillor Allen, and really important points there. In terms of the vacancy position, you're absolutely right. We do build into our workforce planning what we predict our turnover and attrition to be, which we're highly unlikely, dare I say, ever get to a 0% vacancy percentage. But it is really important that we predict as best as we can with the intel that we have from the people on the ground in terms of what workforce we need for the future year coming up. So every year we do a full workforce planning round as a system, which identifies where we can predict as best as we can in terms of that turnover and where the vacancies may be. There's also things we can't predict for in terms of vacancies, for example, maternity leave, secondments, and indeed sometimes sickness where we do have to cover. So there's multifactorial layers to take into account when we're looking at the vacancy position. But we do a deep dive every year into the makeup of our staff as a system, and I'm more than happy to share that with the committee, which shows very clearly where the staff are being recruited to, the roles that they're doing, and what our future workforce for the next financial year we envisage will look like. So more than happy if Chair would agree that I could share that with the committee, and perhaps come back if colleagues would like me to talk through that in more detail. And that would pick up your third point, Councillor Allen, in relation to figures and percentages. We get very data heavy sometimes in the NHS in terms of lots of percentages and figures, and sometimes it's just easier to be able to present to yourselves perhaps the real-time people on the ground and what that means. I think what we have seen on the back of the attraction piece of work that we've done as a system is we are attracting outside of the region to the Lincolnshire system. There is, of course, that natural movement between primary care, acute care, mental health care, and community, where we do see that movement, as you would expect. From an overseas perspective, primarily it's our nursing colleagues that are bringing that are being recruited from an overseas perspective. But we have seen at the hospital a real spark in interest in any roles that we traditionally have struggled to fill. And I think that's to do with the hospital now achieving teaching status and coming out of special measures and really positioning itself as a strong employer to work for. So I hope that answers your questions, Councillor Allen. Thank you.
I think it answers the question in terms of that you do accept that there's perhaps a need for a deeper dive in terms of actually looking at the figures so that we can have a greater understanding of them. And that deeper dive, I think, ought to take into account, if we're looking at a proper people plan, the natural vacancy rate that you operate under in terms of providing your responsibilities, because you've got the actual number of staff that you require. It's just that there's always going to be some churn in the numbers over a period of time. It may well be that the people plan needs to take into account the growth in staff that you need to consider over a period of time as the responsibilities and demands on the Lincolnshire service start to grow. It may well be that you do require to actually overman the service because of particular levels of sickness that operate within the organisation itself as well. So I think all those sorts of figures I think would be very useful. The other figures in a deep dive that I would be interested in is the number of frontline staff that we're talking about within these growth figures as opposed to backroom staff. Because it's obviously, I think, front room staff that are actually dealing with patients and dealing with medical issues that I'm particularly concerned about, rather than the backroom staff, although I accept there are some importances there. So more information, I think, would be great, would be useful to us to understand that what we're seeing in a very broad picture here, Chairman, looks fairly positive, but we need to understand that it really is positive, I think, and it's got some long-term elements in terms of tackling some of the problems that we're going to see in the future.
Thank you, Councillor Allen. Simon, did you want to just quickly get some clarification?
Yes, thank you, Chairman. I just wondered, can I just check? Was it that you said that the ULHT is achieving or applying for teaching hospital status? I think you said achieving. Is it still an application? Still an application? Yeah.
Sorry. Thank you. Thank you, Simon. The application's been approved for our teaching status.
Right. Okay. Thank you.
Thank you.
Okay, thank you for that clarification. I've got Councillor Kendrick next, please.
Thanks, Chairman. Historically, recruitment to the coast and rural areas has been a problem for as long as I can remember in Lincolnshire. And I noticed on page 31 of the report, there's Grow Our People section. It says continue to create an impact through the rural and coastal programme. I'd be interested to know to what extent there has been an impact created. It's a generalist statement. I don't know if there's any data to back up how this has actually been achieved. Thanks, Chairman.
Thank you. Can I come in, Chair?
You can, yeah. I'll have to apologise. I can't see you on the screen always, so just come back in. It's not a problem.
Thank you, Councillor. Thank you, Councillor Kendrick. And I think that's a really important point. And we're doing lots of pop-up workforce hubs in some of our harder to reach rural areas, including Skegness and some of our less able to access some of the things that we're doing in Lincoln cities, etc. So I think there's still more work to do. We are looking at how we can utilise some of the national funding as outreach to contact and ensure that we're linked in with the workforce, both from a health inequalities perspective, because we know if our population are in work, it improves their health position. So there's a double bonus in some respects in terms of trying to get our local people into local roles. And I think this links into the work that we're doing with our educational providers. I think absolutely it's a transformational agenda, and it's something that it features as part of our 5-year work plan. It's in our NHS long-term workforce agenda, but still lots to do on that. But we are acutely aware we need to get into the rurality of some of our areas that are harder to reach, both from a patient perspective, but also ensuring that we're offering the same employment opportunities to individuals who traditionally might not have thought of a career in health and social care. So it's how we continue to do those outreach hubs. I think it's going to be really important, and the use of our digital platforms as well, as we utilise our websites and our branding more to help reach those harder to reach areas. So really good point, Councillor Kendrick. Thank you.
If I could come back, from what I can recall, it's always been a problem to recruit senior clinical staff to particularly the coastal area. I'm thinking of Pilgrim Hospital and places like that. How are you going to address that? I know it's not been an attractive area. Will the teaching hospital status of ULHT actually help with that?
Thank you, Councillor. You're absolutely right. It has in the past been very difficult to recruit certain clinical roles to those areas, specifically our Pilgrim site. We're offering alternative roles, rotational roles, and we've seen a huge spike in interest since achieving the teaching hospital status, which we are now moving towards, hopefully trying to achieve university hospital teaching status, which will help attract talent into our harder to fill vacancies. There's still work to do on some of our medical staffing vacancies in our acute trust, but they're nationally quite hard roles to fill. So we're not unique in terms of the challenges, but we do have the rural challenges on top. But by being in the group model now, so the community and the acute trust are now formed as a group, hasten to add, it's not a merger. We are working together as a group. Again, that enables us to attract a different type of talent with a different type of role, which offers more experience and portfolio perhaps than traditional roles may have offered in the past. So we're looking at exploring the benefits of doing something different now we're a group. So I hope that answers your question, Councillor Kendrick. Thank you.
Thank you. I've got Derek now.
Thank you. Just to pick up on this point, I think obviously there's a huge amount of work going on from an NHS side about workforce recruitment, retention and training. There's also about models of care, and we've got to fundamentally change how we deliver our care. And it was just mentioned there in terms of the move to a group, allowing us to start to move services out of bricks and mortar hospital bases in Boston or Lincoln when we don't need to have those services there, is going to help to improve access. We've got a whole range of work, and I'm sure we'll hear about it from the LMC in a little bit, around how to supercharge community and primary care as well, so that we can deliver more closer to people. That in and of itself, I think, will help to attract new people into the service in terms of staff, because there'll be more and interesting roles. The point about linking into the university is also really attractive.
Thank you. I've got Councillor Burke next, please.
Thanks very much, Chair. I'm going back to page 24, and in fact a lot of the questions I wanted to be asked has been asked by Councillor Smith and Allen. So it's only on a small area that I'm interested. There's mention of churn, it was already been mentioned. So I'm interested in measures that might reduce churn, although I appreciate, as reasons that are being given, this is difficult. And as somebody that in a previous life when I worked for a living was involved with managing services, I'm quite interested in the management interactions that are planned. I've noted that the response to some of these statements, love my job, etc., but don't always like going to work when we're encountering management. And I'm wondering, I'm grateful that you're going to share the deep dive, and I think that's really useful. And I'm wondering what measures you're planning to take to deal with some of these staff morale issues. Thank you very much.
Thank you, Councillor Burke. Really good question. I think there's two aspects to it for me in terms of sort of the cultural agenda. There is the group transformation that we're currently going through in terms of the culture change there. So there's a lot of work going on in terms of engagement, communication with the staff, both from a community perspective, but also from an acute perspective, because there's some nervousness, as you would expect with the big change of moving to a group model. There's a lot of work ongoing from an OD perspective in terms of drop-in sessions, live Q&As with all the directors from across both organisations. And you may be aware, colleagues, that we've just recently recruited a new group chief executive. Andrew Morgan is retiring at the end of June, and we've just recruited Professor Karen Dunderdale as the new group chief executive. So I'm sure Karen, in her role as new group chief executive, there is a lot of work to take on board in terms of managing staff through that culture and that change curve, because there'll be a lot of nervousness and worry, I think it's fair to say, in terms of what does that mean for me. So it's really for the executive team to lead that forward, including myself, to offer that assurance, but actually to offer the opportunity that it's going to open up doors for portability of staff, the opportunity for new roles that don't currently exist, and ultimately it's better for our patients. And I think that's the important thing that mustn't be lost in the big change management piece of work. I do think that the deep dive will offer some more assurance in terms of the work that we're doing with our national staff survey results. So we're working with each of the departments and the department heads in terms of, this is what your staff said in the staff survey results. These are the good things, and these are the things that the areas that need some more work. So it's not, and I hate this expression, so please forgive me, but it's not a tick box exercise. Our staff have told us something in the staff survey results, good and bad. So we need to actually have a real focused effort on what our staff are telling us from the National Staff Survey. And that piece of work has commenced, Councillor Burke, in terms of, this is what your staff have said about working for you in your department, and we've drilled it down to a real local level. So it's a bit of a warts and all in terms of some positives, but there's work to be done. And I'm supporting that from an educational, and making sure all our staff have an up-to-date appraisal. So important. How are we capturing that? So there's a lot of work going on behind the scenes to ensure, A, that we support our staff through this huge change, but also that staff feel valued and that we've got their basic needs met in terms of they've got an up-to-date appraisal. We know if they want to develop or do further training or have interest in doing something else, that we're capturing that and really supporting our rising talent. So, but I think the cultural question and the OD work, there's a lot to do, but we are fully sighted on that, and it is so important that we take our staff with us on this engagement journey and they don't feel that it's being done to them. So I hope that gives some assurance. Thank you.
Thank you. I've got Councillor Pessold next, please.
Thank you, Chairman. I note that there's plenty of reference made to flexible working and creating a conducive work environment. In light of the impact of COVID, I'm curious as to what other adjustments have been required, and whether being able to adapt to that sufficiently has had a noticeable impact on staff retention. And also, as a sort of separate point, have the exit questionnaires and other feedback measures hinted at an issue with actual staff morale and mental health, and how are they being supported, both in terms of the impact of the current situation on their health and how they feel their interactions with patients impact their health and their work.
Thank you, Councillor. With regards to the flexible working element, I think from COVID, we all realised that we didn't all have to be on site 24/7. So certainly the hybrid working that has now become acceptable has massively supported the retention agenda. We have a full formal process now for staff to request flexible working, and colleagues may know that's now a legal requirement for employees to have the right to request flexible working. And we have a really high, I think it's about 97% acceptance rate across the system for any flexible working requests that go through. And we have a full oversight and process to ensure that those requests from staff are given the proper consideration from their line managers. So it's a very thorough process that's now in place and has actually been accredited as a system. So that's certainly making a difference in terms of our retention agenda. So staff no longer feel that, you know, if the hours they work or their personal circumstances change, that they have to leave, that they have another alternative. I think certainly from a recruitment perspective, it's opened up the boundaries in terms of us being able to recruit from outside the region and attract talent into the region that perhaps logistically hasn't been achievable when staff were required to be on site full time. So that's certainly made a difference in terms of us being able to recruit into the Lincolnshire system. I think in terms of health and well-being, it's something we're really focused on, and we do look very with regular review at our sickness statistics across the system. The highest reason for sickness in health and social care, unfortunately, remains to be mental health related reasons, which has been the number one reason for our staff sickness for some time. And we're doing a huge piece of work in terms of what else can we do as a system to support staff to remain well at work. Because you could argue that by the time staff have gone off sick, we've missed an opportunity already to offer support. So we have dedicated health and wellbeing teams, health and wellbeing champions. We have on-site counselling services. We have fast track available to the Mental Health Trust for our staff. And we've just concluded a full occupational health review for the Lincolnshire system in terms of how best we can serve our staff to keep them well at work. So there's a huge piece of work following that review, which was conducted by an external expert in terms of what are we doing well and what do we need to improve. The Acute Trust have just launched a menopause doctor-led service for our staff, which is making a massive difference for our female members of staff, and we're looking at rolling that out across the system. And that was the first of its kind in the UK to be a doctor-led menopause service for staff only. So there are lots of innovative ideas that we're absolutely introducing to the benefit of our staff, but there's still a lot to do. And some of that will come down to work-life balance. Some of it's outside of our control and is personal stress. But again, it's very much our responsibility as a caring employer to make sure we offer our staff the best help that they deserve. The other thing that we're doing in the Community Trust is offering staff, it sounds a little bit cliche, but we're sending them a get well card when we know they've gone off sick, because sometimes staff struggle to access the services that we have to support them because they may be off with work-related stress, and the last thing that they want to do is log on to their computer to access those services. So we are piloting the Get Well card, which is merely a way of us being able to say we care, and here's all the services that you may want to think about reaching out to for help. And early indications of that pilot are that staff have really been receptive to that, knowing that somebody's noticed that they're not at work and we care about their health and well-being. And please contact us if there's anything else that we can do for you. But I think some of the work, if we get better completion rates on our exit questionnaires, it's going to give us more information that we can work on as well. So that's got to be a key priority for us in terms of gleaming why staff still continue to leave. Thank you, Councillor.
If I could just briefly come back. Is there any chance that we could get on the deep dive that has previously been mentioned, some greater statistical breakdown of how sickness rates are being affected, both in terms of physical and mental causes, just so that we can get a better picture sort of across the county as well as to where, if we have any hot spots for this sort of thing, because resources do vary to an extent across the county, and I'm just curious whether that leads to a higher rate of staff illness, be that physical or mental.
Yes, absolutely, Councillor. And I think one of the main drivers is ensuring, I talk about, it's really important that no matter where you work, you have the same access to support across the Lincolnshire system, and it shouldn't be an employee lottery in terms of, I work in this organisation, so therefore I get more support than I would if perhaps I worked in primary care, for example. So there is a big piece of work linked to the occupational health review in terms of that equity for all. Still work to do there. We're not quite there yet in terms of that offering for all of our health and care staff. But absolutely, we can drill down into those hotspot areas as part of that deep dive to give that further breakdown of that information in terms of the physical and mental sickness statistics and the impact that may have on the different elements of our health and social care workforce. Absolutely.
Okay, thank you. I've now got Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. I'm very grateful to Councillor Kendrick for bringing up the issue of the East Coast, because we are always the poor relations, and sadly, there never seems to be an answer other than it's very difficult. And I think it's about time we woke up to that and remembered that we're all entitled to a similar amount of treatment. I want to go on to page 25, where it says creating a strong sense of community, creation of local hospital hubs aligned to the local community to amplify the natural connection with local healthcare. I can say, hand on heart, that the town that I represent, Louth, is less integrated to our local hospital than I can ever remember in the past. That certainly isn't working here. I don't know any local schools that you're going into. Perhaps you'll tell me that there are some. And I think it's really sad. The hospital should be a lot more important in our community than it actually is. So I'd be interested to know what your plans are for that, please.
Thank you so much, Councillor. And I actually live in Grimsby, so I know Louth very well and very dear to me. So I myself spend a lot of time at Louth, and I know we're in Louth schools, so I can certainly provide you with that detail. I don't have the exact names to hand, but I can certainly do that. And I know, obviously, with the creation of our CDC unit in Louth as well, that's making a huge difference in terms of our patients receiving the access they need in the right places. I think there's still work to do, and I do hope that the work that we're doing with the local education providers is really going to link in more with our areas that are outside of the the core Lincolnshire area. But Louth is very dear to my heart, so please rest assured it's very much on my agenda in terms of getting that where it needs to be, and the hospital very much valuing the staff that work in our Louth hospital, and that they feel very much a part of the health and care community. But I think there is absolutely presence at schools, and we do a number of career events that school children are invited to from that catchment area. But I can get you the specific details just to offer you that further assurance. Thank you.
Thank you for that, and I'm glad you like Louth. Thank you.
I love Louth.
Thank you. I've got Councillor Morgan next, please.
Thank you. Just going back to page 24. If we actually read the comments provided, there's quite a few somewhat concerning around management and style of management, referring words like clique stand out to me. What training do you actually provide your managers? Is there sort of an assumption because someone's been in a job for a long time, maybe very good at doing operational work, that somehow they're suddenly going to be a really good manager? Do you actually, first, so what training do they actually get? What monitoring of them do you actually give? And if we look at the turnover, we're looking at very high level figures. I think that's point's been made. But do you actually analyse those figures by department or even down to managerial level? So if you have got issues, you can identify them and work with the people concerned. That's one area. The other I know has had an impact on some staffing is the loss of creches on our sites, and I wondered if you're reconsidering that policy given the impact that it's had, especially on I think nursing staff, because of the hours that people are working. But I'll just leave you with those thoughts. Thank you.
Thank you so much. So just with regards to the management skills training question, I think in the past, and certainly I've been in the NHS, gosh, nearly 20 years, there was perhaps poor behaviours of people being promoted from a peer to a leader without necessarily giving the tools or the training to make that transition. And that certainly with my HR experience has caused some issues in my career in terms of then having to pick those elements up. I'm pleased to say that we do run what we call a Brilliant Basics course, which is for all leaders at all levels, because there has again in the past been a tendency to focus training on higher level managers. This is a training opportunity, which is a module online based course, which is run by the acute hospital but offered to all, and it's all managers no matter what band you are, and it teaches you how to do the brilliant basics brilliantly. So how to have a difficult conversation, how to have a sickness meeting, how to give a good appraisal, how to have a constructive conversation when it's a difficult subject, all the things that you would expect a leader to have experience in. Sometimes, you know, and some managers that have been on this course have indeed been leaders for many years, but they've used it as an opportunity to refresh their skill set. So it's not just new leaders that are joining that course, it's leaders that have been in post for a long time that are looking to refresh their skill set. And things change in terms of HR requirements, ensuring our protected characteristics in terms of some of our staff groups are offered the right assistance and opportunities. So I'm pleased to say that's a really really important course that has a lot of uptake from our leaders. In terms of monitoring, we do hold monthly meetings with each of the main directorates in which we look at turnover, we look at sickness rates, we look at retention, we look at the vacancy position. all in its totality in terms of a triangulation, because what that then tells you is a different picture. And that may also link to what's the appraisal rate for that certain area or manager. Is the statutory and mandatory training up to date? And you start to see the red flags, councillor, in terms of there's something not quite right here. There may be some freedom to speak up or PALS complaints linked to that area as well. And that piece of information is all triangulated to say there's something here that we need to look at, and that's done on a monthly basis with each of the divisions and the senior triumvirate. So we do look at that in terms of are there any patterns or behaviours that we need to be aware of that in isolation could be one or two, but when you pull them together in terms of the triangulation piece of work from a cultural perspective, there's something to be worried about here. So we need to get involved. So I hope that answers that question. In terms of the loss of creches, I'm not aware of any closure of any creches, and indeed the creche at Lincoln County, I believe we're in consultation with the creche company who run the services as a business to look at how we can extend the hours for our shift workers, because childcare is not, as we know, just a 9 to 5 requirement. How do our staff that need childcare out of hours get that support? So we are actually in conversation now with our one of our creches to look at how we expand the opening hours rather than closing. So it's absolutely supporting our staff with that work-life balance. It's something we're very acutely aware of and trying to again look at expansion of the services for that. And then hopefully, you know, if we can look at the other creches, if we're able to do that for one creche, then we're certainly not looking to close creches. Absolutely not. That would, as a working mum, that would be something that would not be conducive to being a valued member of staff if we're looking at closing creche facilities. I hope that answers your questions. Thank you so much. Really good questions.
Thank you. I'd just like to, if I may, thank you for that. Just with the creches, can you just clarify if Grantham Hospital has a creche now? Because it did used to have one, and to my understanding, no longer has. Can you just confirm that if that's the case? And if not, can we get one, please?
Thank you for the question. I'm not actually 100% sure. So rather than giving you a false answer, I'd like to take that away and just double clarify. My understanding, I thought we did have a creche in Grantham, but if that's not the case, I don't want to give you false information. So please, may I take that question away and offer you an update following today's meeting, Councillor? Thank you.
Okay, thank you. I've got Councillor Smith very briefly, and then I'll bring back Councillor Mackinson-Saunders very briefly as well, because I've got a couple of questions and I want to close down the debate.
Thank you very much for your indulgence, Chairman. It's very much appreciated. I may only nearly be 30, but when I hear an organisation like the NHS or His Majesty's Armed Forces utter the words flexi-time in contracts, my heart fills with dread. And I may sound very old-fashioned, but certainly I'll use the forces context because that's my family background. When you joined, it was those are the hours. That is what it was. It wasn't a job. It was a way of life in the forces, and I worry when, and I know why it's done, because in most normal jobs you have that option, but the NHS, the forces, they're not normal jobs, Chairman. So how in reality does that work? Because if you're giving everybody flexi time, how do you then fill a really unpopular time that nobody really wants to do, but somebody's got to do it because someone's got to be on shift? So nobody really wants to be on at 1 a.m. on a Friday when everybody's, quite a few people have had too much to drink and you're having to deal with people who've potentially got alcohol poisoning or other issues around that sort of thing. So how does it work in reality where you're doing this? And I know why you're doing it, because it's the in thing and it helps retention, and I know why it helps retention, but how does that work in reality around actually making sure you're staffed safely in the unsociable hours and the hours nobody really wants to do, if they were honest? Thank you for the indulgence as well, Chairman.
Thank you, Tom. Before I bring in our presenters, I will say that flexi time has been very handy in terms of bringing back retired people as much as anything, which has dug out the NHS quite hugely over the last period. But I'll hand over to our presenters.
Thank you, Councillor Smith. Yes, and I think historically flexible working requests have always been a challenge for the NHS because the roster says no. So I think the way we've been able to navigate through the balance of still filling our shifts, but also ensuring that staff have the opportunity to request the difference is, in the past, certainly, I think there's been a regimental approach to rota planning, for example, where it was one long shift and that was the shift that you did. Now we're much more flexible in terms of being able to plan that rota. So some staff, for example, only want nights because their partner can look after their child at home. Some staff only want weekends because of childcare reasons, stuff, you know. So what we've been able to do is manipulate the rosters better. So short shifts can be offered, and then we offer staff the opportunity to fill that rota. In some, we can't always approve the flexible working request, and as you absolutely say, you know, certainly for our patient-facing colleagues, shift work is absolutely part of the role. But there is the opportunity to job share. There's the opportunity for part-time hours, and I think that in itself has really opened up the ability to work with our staff in terms of, if you cannot work shifts, then we need to look at alternative roles, perhaps in outpatients where it's in your normal working hours rather than shift-based work. And we've been able to look at alternative roles as well as part of those flexible working requests. So there is absolutely a balance of making sure that we're filling our shifts with staff, balanced against the needs of the service, balanced against the requirements and the requests from staff. So it comes with a sensible conversation in terms of what are the service needs and can we look at the rota to flex that request. And in the past, traditionally, it's always been no, every shift's 12 hours. And if you can't do your 12 hours, then unfortunately the computer says no. So we have moved away, thankfully, away from that regimental approach. But I do think the flexible working has enabled us to attract reservists as well, who are ex-forces, into part-time work, sometimes via the bank, and then they've gone on to achieve employment, which has been a really good success story for the Lincolnshire system as well. We have a huge amount of reservists that support us and have certainly helped us during times of recent strike action, where we had up to 80 shifts completed by our reservists. And some of those reservists have now moved into permanent roles. So, and as Chair mentioned, retired members of staff who wish to come back on a flexible working arrangement and may not want to do on-call provision as a medic, but still perform clinic activities again. So it does open up the opportunities of a different workforce and what that can look like. So thank you, Councillor Smith.
Thank you. Councillor Mackinson-Saunders.
Yes, it's just a very quick question. We've heard a lot in the national news about nurses having to use food banks, and they're not the least well-paid members of staff in the NHS. And I wondered what the NHS offers people that are struggling. It's very difficult to admit you're struggling, but is there somewhere where you can scoop up help for people who've got debt problems and things? How do you go about that? Helping those people through what we're doing in Lincolnshire, please.
Thank you. Such a sad state of affairs, isn't it, where staff members have to use food banks, and we are very much aware of that. And there are a number of staff benefits, discounts that we offer staff by being such a huge employer that are offered to us in terms of discounts, etc. In terms of debt management, part of our employee assistance programme offers debt counselling and debt assistance, which is totally independent and confidential. So staff can reach out to that debt advice line, which is provided by an employee online assistance programme. So that employee online assistance also offers face-to-face psychological support, counselling, breakdown of marriage, debt support. So it's not just work-related stress that it can support. There are all the other elements that can cause stress in our staff that are covered as part of that employee offering service. I think what's key for us moving forward is making sure, as I made reference to earlier, that that support is available for everyone and not just for the core employers. I think we need to ensure that there's a full implementation of that support for all staff in the health and social care setting. Thank you.
Thank you. In which case, I've just got a couple of questions myself. My first is, I understand that the Lincolnshire People Plan for 24-25 is not yet approved. Will you be able to circulate it to the committee when it is?
Absolutely, Chair. No problem at all.
Thank you. My second is, what do you think has been the most significant achievement from the People Plan and its activities in the last year?
Oh, that's a good question. I think the work of the People Promise Managers, the retention agenda and the improvements that we've seen on our staff survey. So although we know we've got work to do, our staff aren't voting with their feet anymore. We're keeping our staff. Staff feel more valued. And certainly from an acute perspective, in the 22-23 National Staff Survey, we were the second most improved trust in the UK in the National Staff Survey for retention and feeling valued by our staff. So I'm really proud of that. I think there's still a lot to do. But the retention has enabled us to fill the vacancy gaps. The staff aren't coming to work with huge staffing vacancies anymore, which undoubtedly put a lot of pressure on them. Working with temporary staff as well. So we've enabled a huge reduction in agency spend, certainly at the acute trust to the value of 17 million. We've reduced the agency spend in 1 year from 2023 to 24. So that for me feels, the strongest thing I'm proud of, Chair, in terms of it feels different for our staff on the ground, in terms of coming to work with staff that they know, without covering gaps, without being moved to fill other gaps. And that for me must offer more role fulfilment and job satisfaction and better care for our patients ultimately. I think that would be the one thing that I'm most proud of. Thank you, Chair.
Thank you very much for that. Are there any particular staff groups or specialities where recruitment and retention are more challenging? And if so, are there any specific plans to address these areas?
I would suggest the biggest area for challenge is still our medical and dental colleagues. And there is a dedicated piece of work now being undertaken for 23-24 in terms of those really hard to reach vacancies. And we can't simply keep putting the advert out and hoping for a miracle that we manage to attract somebody to that role. So what can we do differently? How are we going to retrain or reevaluate the role itself? Can we do something different? Can we get a nurse consultant in to do that role? So certainly from an acute perspective, the medical vacancies was around 12% in 2021. We have halved that to around 6.1%, but there's still work to do. And that's certainly the focus for 23-24, because that gap at this moment in time is still filled primarily by expensive temporary staffing. And there's a real drive to, if we cannot recruit the staff, then we need to do something different. Saying that, we have halved the vacancy rate by the attraction and retention elements that we've discussed earlier. But there's still, excuse me, some renownedly difficult posts to fill that even big university teaching trusts struggle to fill. So again, how can we utilise the dynamics of the group and change the rotational aspects of the role to make them more attractive? Again, is now within our gift to look at doing something different. Thank you, Chair.
Thank you very much. And my final question is, Councillor Mackinson-Saunder answered the question earlier on, and I could have sworn I heard you say that there was plans for a CDC at Louth. Can you clarify if that's correct?
My understanding, sorry, it's a UTC at Louth, isn't it? My apologies, wrong acronym. There's an urgent treatment centre at Louth, which I know is very much in the hub of the community. I think the CDCs are Grantham and Skegness off the top of my head. So apologies, that's
That's absolutely fine. I just thought I'd pick up on it because it would have been quite
Yeah,
exciting
thank
for
you.
Councillor Mackinson Saunders elsewhere. So thank you. Okay, in which case I'm going to move to a proposal, and that is firstly to thank the presenters for their reports and presentation, to welcome the achievements of the last 12 months, including the sustained fall in the vacancy rates at the Lincolnshire Partnership NHS Foundation Trust and at the United Lincolnshire's NHS Trust over the last year. And finally, to seek an update in 6 months' time on the progress made during 2024 to 2025 and to receive the 5-year work programme. Do I have a seconder for my proposal, please? Councillor Mackinson Saunders. All those in favour, please show. Thank you. That's supported unanimously. So we'll now move on to the next agenda item. So we'll move on to agenda item 6, GP provision. This item was circulated as part of the agenda pack on pages 33 to 78. This item comprises of 2 reports, one from the Lincolnshire Local Medical Committee and the other from NHS Lincolnshire's Integrated Care Board. My plan is that both reports will be presented to the committee before we take questions, and I'd like to welcome in person our presenters, Dr. Reid Baker, Medical Director from Lincolnshire Local Medical Committee, Sarah Jane Mills, Director of Primary Care, Communities and Social Value for NHS Lincolnshire's Integrated Care Board, and Nick Blake, Programme Director for Primary Care, NHS Lincolnshire's Integrated Board. And I'll hand over to you for the presentations and we'll take the questions at the end. Thank you. Sorry, I should have been clear. It's not being used to having you back in the chamber. Yes, if you could press the microphones as you speak and press them off when you're done. Thank you.
Thank you, Chair. Thank you, Committee. Thanks for having us today. For those who haven't met before, I'm Dr. Reid Baker, Medical Director of Lincolnshire LMC, and I'm a GP in Woodall Spa in the centre of Lincoln. Hopefully you've all had a chance to digest the report that I've submitted to committee, obviously happy to take questions once Sarah Jane and Nick have also presented their report to your good selves. But to summarise, as I've put in my report, we are under, in general practice in Lincolnshire, ongoing pressure due to a multitude of pressures that are facing across both the NHS and the wider economy in the UK, including the inflationary pressures, cost of living rises, and real-term contractual funding reductions across general practice, which is a challenge when we have an increasingly elderly, medically complex population that need our care and support. Despite that, in general practice in Lincolnshire, we're working extremely hard and delivering activity levels above comparable regions in England, and we are very proud of that and continue to work diligently to give as good a service as we possibly can to our population. As I'm sure people will be aware, the recent GMS GP contract referendum had a 99.2% voting rate against this being a contract that was safe and sustainable for general practice and our patients. And I think it's a really strong message nationally that our practices, our patients deserve better and more resourcing and support into general practice. And I hope we would all be supportive of that thought. The delivery plan for access, recovering access to primary care is now a year into existence. It's provided a useful platform to move forward some discussions we were already having in Lincolnshire to increase capacity in general practice by releasing some of the work streams we're already doing and absorbing from our secondary care trust colleagues. And I think that is a positive note we'd like to see accelerate in Lincolnshire for its potential for our patients and our practices. And I think overall, as I'm sure we're aware, the overall health and social care system in Lincolnshire is, as it is nationally, under a lot of pressure due to some of the things I've already outlined today. Hopefully that economic situation will improve. Hopefully that means more support going forward for the NHS and obviously from my perspective, particularly general practice, so that we can move things forward for our patients and our population. I'll leave my summary there. I hope that's useful and I'm happy to take questions as we go along. Thank you, Chair.
Thank you, and thank you for inviting us back. I'm actually going to hand over to Nick because I'm a bit croaky today, so Nick will take us through the primary care report.
Good morning, everybody. Nick Blake, Programme Director for Primary Care at the ICB. Again, I'll take the paper as read, just to pick up a few key points. First of all, just to recognise the hard work across all general practice in Lincolnshire to deliver the services that patients require. We continue in terms of access to see a really high number of appointments being delivered to patients across Lincolnshire. Over the last 12 months, I think about 5.4 million appointments delivered and around 500,000 in March, which is the latest data we have available to us. Again, there's data in the reports. I won't go through that particularly, but again, you can see maintaining good levels of access across GP practices, but with ongoing work to do. As well as work with GP practices, we're working with primary care networks, and the paper sets out some of the key programs of work. So projects around high intensity users, so people who more frequently attend hospitals or healthcare settings, and providing additional support to those people to try and make sure their needs are met and to reduce the need to attend things like emergency departments. Some evaluation is underway on that piece of work, and I think we're seeing some really positive outcomes from that already. I also work with PCNs around the frailty strategy and delivering that with 5 early adopter sites across the county, focusing on slightly different areas. Early stages on that, but again, I think really positive work, and it will really support those people that Reid mentioned that have more complex needs and provide care to them in a different way to meet those needs. So I mentioned access. We carry on working on the Access Recovery Plan this year. This is year 2 of the Primary Care Access Recovery Plan. Key areas that we'll be focusing on is work around pharmacy first and extending community pharmacy services. So that's enabling patients to be treated for some ailments and conditions via the pharmacy. Also to have things like blood pressure checks and oral contraception prescriptions, if appropriate. And working with GP practices and pharmacies to integrate and support them to communicate with each other. Again, some IT issues at the moment which we're working with both GPs and pharmacies on. One of the other areas of focus around the Access Recovery Plan this year is going to be around self-referrals, so supporting people to be able to access services directly without having to be referred by a GP or another health professional. Again, we'll be doing some work to promote those locally to people. We've seen numbers of self-referrals increase over the last 6 months, and we'll be doing some work to expand those pathways, so particularly working with our Community Health Service Trust. Currently they provide self-referrals into podiatry, etc. District nursing, things like cardiac rehab for people recovering from heart problems, and again we'll be working with them to expand those pathways. Around access and supporting GPs, we mentioned the report around our resilience frameworks, how we're reporting GP practices to be resilient and provide sustainable services. We're doing work around digital as well with practices to support that, so supporting practices with telephone systems and online consultation tools, but also looking at things like estates and workforce. I think you've heard about workforce, so I won't go into that in any detail, but we're doing some work, continue to do work with PCNs around estate strategies, but also doing some work in year to support GP practice to make best use of their existing premises, so expanding into developing clinical rooms within existing estate, etc. But again, really just support capacity and make sure that practices can house their staff but also see patients. All of this, and I think the important thing to really raise today is around the work we're going to be doing around our GP strategy over the next 6 months. So we currently have a dental strategy which sets out the delivery of the Dental Access Recovery Plan locally. We're also in the process of developing a community pharmacy strategy, and we're going to be developing a GP strategy too, and all of these are going to be interlinked and really support integration across primary care, so with the new commissioning arrangements for the ICB, really allowing us to look at how we make best use and link together those primary care services, but also link them and integrate them with community services and other services within the wider health and care system. The GP strategy is really going to be looking at how we address some of the issues that Reid raised and are set out within the fuller report and the Access Recovery Plan through integration. So how do we improve access for patients into general practice, but also where patients have more complex needs, need continuity of care, how do we enable that continuity of care to be provided too? The timeline for that is to develop the strategy over the next 6 months, so we should have a draft ready towards Q3 of this year. I think those are all the key points I wanted to raise, but again, of course, happy to take any questions.
Thank you very much. First question comes from Councillor Allen.
Thank you, Chairman, and thank you, presenters. It seems to me that in Lincolnshire we're starting from a fairly poor base in terms of the number of GPs that we actually have for our population, particularly bearing in mind that our population tends to be more older than perhaps the rest of the East Midlands. Although we do have a lot of additional staff working in the practices, the GPs and the GPs in training do seem to be below the average for the East Midlands. The other issue that I seem to find from talking to doctors and from my personal experience with my practice is that the primary care sector at the end of the day is a privatised sector. You're operating in a private network, and the general practitioners, general practices are private businesses to all intents and purpose, and that these demands on the general practices in terms of providing better patient care with additional staff, or providing additional care in the community, because it's not just the £165 you get from each patient on your list. You do have other responsibilities and other earning potential, should we say, with the private care sector and so on. And there are more and more people who don't want to become partners in general practices, quite happy to work as locums or quite happy to work as salaried GPs, but they will presumably only want to work that's 36 hours or 4.5 sessions or even 4 sessions a week or whatever it is, But I find that there's more and more pressure on the actual GP partners to look after their businesses at the end of the day. And that takes time, and as a consequence there's less time then devoted to the patients and more reliance on the support staff or the salaried GPs, which has some difficulties then in terms of continuity of care of patients and gaining access to the patients. And whilst the number of doctors that we've got seems to be either static or, according to the government, actually increasing, the actual amount of work that we get out of those GPs doesn't tend to actually reflect the numbers, because there are these additional demands, whatever those demands are, whether it's the local medical committee or anything else. But it does seem as though the GPs then struggle to actually provide, a great deal of patient care within their practices. So it seems as though numbers of doctors is part of the key to it, as well as trying to encourage them to work as much as possible within the practices on patient care sort of issues. And this is something that we've said time and time again, I suppose, that are we actually increasing the number of GPs in Lincolnshire, particularly in the hard to service areas on the coast, because while staff numbers go up, it's not necessarily the numbers of GPs that go up, and we don't always seem to get the output that's required then to actually address the fundamental issues in terms of being able to provide appointments for patients and to actually see patients on a face-to-face basis rather than necessarily simply relying on telephone consultations and the triage system that gets you into that system, which doesn't always work very well in my view. And as my GP, which I do tend to use as much as possible, is very much like the 8 o'clock session on the telephone. It's full up by 9:30 or 9 o'clock because they opened it earlier, and you still don't find it's easy to gain access to the practice. It does seem as though numbers are key to it, and I'm not totally sure the recovery plans really put an awful lot forward in terms of giving any encouragement that the numbers issue is going to be actually resolved. And who's at fault in terms of doing that, whether it's the government and medical places, whether it's recruitment from outside, whether it's actually keeping doctors doctoring as opposed to doing other things, either talk radio shows or whatever it is. I haven't really seen anything that answers that fundamental question about how we increase the number of doctors in general practice, in the primary care sector, and actually keep them doctoring and looking after patients.
Thanks, OJ. Thanks, Councillor Allen. Quite a bit you covered there. One fundamental question. Maybe I'll have one question back for your good self as well, just for some clarity, if that's okay. In terms of what fundamentally does that come down to? Working conditions, doesn't it? If we have GPs and other colleagues in general practice who are working in an environment where they are working, doing something they enjoy, in an environment where they are supported, where there's plenty of resources and colleagues to support them, and they are seeing those patients. We get a great sense of positivity in our roles when we are seeing patients and we are helping patients. When some of the other external factors, including increasing administration, the financial pressures, particularly, as you say, about GP partners, keeping the lights on and the doors open in their own GP practices, because they want those patients to be able to access their practice. They want to deliver high quality care to those patients. Those are the things, as well as some of the other pressures when it's made to feel like general practice isn't working hard enough, and obviously I've alluded to some of the statistics there, that we're working and doing more than we ever have with less resource, and resource can be finance or people or estates and infrastructure. That's the real challenge, because when I talk to my colleagues, and hopefully when you talk to fellow doctors and GPs, no one says, I don't want to do the job. They say, I want to do the job, I want to do it really well, I want to help those patients, but we can't continue to do it in this fashion with the infrastructure nationally that we are given in general practice. Now locally, the ICB are trying to support, as Sarah Jane and Nick have alluded to, with some of the pressures that we feel. But there's a certain limit to what can be done. And I think what we are seeing more and more, unfortunately, we've been saying this is going to be the case for years, is that GP colleagues and other colleagues within the practices have worked far and above where they can for a long period of time, and they can't sustain it, and people do leave. Unfortunately, I've had a GP partner leave for my own practice in the last couple of months. Love the job completely, loved working within our team, but the pressure of the job is really hard. So it comes down to working conditions, okay? Job satisfaction, having the infrastructure, having all the linked in and integrated services that mean that we can do that role that we were trained to do. In terms of doing other jobs, yes, we do other jobs. That's why I'm sat here right now talking to you clearly. Why do we do it? Sometimes it's personal interest, okay? We all have to think. One of my colleagues does surgical procedures sometimes as well. There's a wide range of services around any profession that needs an infrastructure and different level around it to help that facilitate those activities. So some of us do it for that reason. Also, we've seen more people to move to portfolio careers for a couple of other reasons, one of which is because of the intensity and the pressure of the normal GP job. People want to do something else that they really enjoy as well, to take away a little bit of that pressure. And actually what we find is if colleagues do that, they might stay in general practice longer than they would have done otherwise, which ultimately is a benefit for our population and our patients. The other reason we do it, is unfortunately, is going back to the financial pressures that are happening across the NHS and particularly in general practice, because we are different in terms of how we are funded, and we don't have the same support mechanisms and safety nets that we have in hospital trusts, etc., is that practices can't necessarily afford to pay people to be working for more days than they are currently working within their practices. Because ultimately, going back to my earlier point, practices need to be viable, because if the practice isn't viable, it closes, and then patients don't have that practice, it goes on to the next practice, the pressure mounts on the following practices. I hope that partially explains. Happy to go back further. The only query I had for your good self was you talked about the opportunity to sort of do work in the private sector. I wasn't quite sure what you meant by that, and I'm happy to expand with an answer.
Sorry, could you ask your question again?
Yeah, you talked about practices being private businesses, and then you said the £165, but there's opportunity to bring in more. I wasn't quite sure what you meant by that, so I was going
It's
to...
just a comment that you are part of the, you do operate within the private sector, don't you? You are private businesses that provide a service to the NHS in effect.
Yeah, we do, but we have one sole customer, so we don't have opportunity to make additional revenue streams by going out.
You don't have contract with care homes?
So no, my practice does not have a
Well,
contract with care home.
not your particular one, but several GP practices do provide to have a contractual arrangement with private care homes, don't they? In fact, it provided medical support for them. Not a great amount of additional income coming in from those sort of sources, but I'm sure, but they are there. My father, when he was a GP, used to be the medical officer for one of the big steelworks in Sheffield. So they do have these sort of other income sources. It's not a problem.
Okay, if we can just try and not have the back and forth, please, and try and come through the chair as much as possible. Councillor Cleaver, please.
Thank you, Mr. Chairman. In relation to the ICB report, I noticed that the section on the quality of GP service provision is quite short and only mentions the current situation with the 2 GP practices which are currently rated as inadequate. There's no mention of the GP practices in Lincolnshire which are rated as requires improvement. And there's no reference to what's happened recently in the last 12 months, for example, with the any change in the numbers that are rated as inadequate, any change in the numbers that are rated as it requires improvement, which is disappointing. There's also, of course, no comparison with comparable figures nationally. So I've had a quick look on the CQC website, and I was quite surprised. So we have, if I'm correct, 2 GP practices at the moment rated as inadequate, 6 more rated as requires improvement out of 81. Now that means that we have 8% of our GP practices in the county, which are rated as, 10% of our GP practices in the county rated as requires improvement or inadequate, and that compares with only 5% nationally. The other thing that I was quite surprised to see was that these tend to be the larger practices. So therefore, those 8 practices represent 14.2% of the patient population, which equates to 116,723 patients. So we have 116,000 patients in Lincolnshire who are registered at a GP service, which is either requires improvement or inadequate. And in that context, I'm disappointed that those points aren't made in the report, and I would welcome your comments on the statistics that I've just quoted to you. Thank you.
Thank you, Councillor Cleaver, and apologies for the lack of detail in the report. Certainly something we can provide in future. I think following the last committee meeting, we did provide a little bit of breakdown on CQC ratings, but happy to provide more detail in future. In terms of CQC ratings, the ICB's quality team and primary care teams work very hard with practices to support them in addressing some of the issues that are raised by the CQC. I think one of the interesting things for us is we've seen a change in the CQC inspection regime recently, and we're working to support practices to understand what that means for them and some of the things they may need to address that are different now compared to previously. We've got a range of support that we offer. We go in and provide visits into practices, and we provide some tools to allow them to understand how the CQC might view them, so IT tools that will do similar searches to the ones the CQC do. So we're providing a lot of support to practices, working hard to work with practices so they can improve their CQC rating. I think in terms of the statistics, they sound accurate to me. I haven't got any comment to make about that. I think the important thing really is that we work together with the practices to try and support those improvements where they're required.
Thank you for that. I'm obviously aware from previous correspondence that you are very conscious of the fact that you need to work with practices and that you do identify those who are having difficulties and you support them. My concern is where I'm looking for some reassurance, is that given that of the 4 reports published so far this year, so we're, 4.5 months into the year, 3 will require improvement, only 1 was good. And I'm just concerned that we have a slow drip effect of this number going up. And I think I'm looking for some reassurance that the measures that you're already taking are going to be adequate to actually nip that in the bud. Yeah, thank you.
Yeah, thank you. As I mentioned, I think there's something around the new inspection regime. I'm not saying that's entirely the issue here, but it's about about us understanding that and supporting practices. But I think we're providing additional support into practices, and we've got currently a programme of work where we're working with practices, particularly one where we feel that they may benefit from some support, but we're working through a programme of support with them, so doing kind of quite in-depth kind of diagnostics with the practices, identifying areas for improvement, and then working with the practices to support them with that. I think we've had some pretty good feedback around that so far, and we saw around 20 practices last year. We'll be looking to deliver that support framework to as many practices as we can. We're hoping to cover the rest of the practice over the course of the year. Some of them, I think we had one outstanding report over the last 12 months actually for Bungalatly, so that was positive. So some of those practices we might not prioritise because they're already doing well and got a good rating with the CQC. But I think the work we're doing will support practices, and I think we'll start to see improvements in those ratings. But I think it is partly down to that change in CQC inspection regime. Again, I'm happy to provide much more detail on that in the future report if that would help.
Thanks for your question. Just to build on what Nick just said there, I think clearly no practice wants to have a CQC report that's less than ideal for them, and patients don't want that either. Understandably, they want the reassurance and the safety net that the practice is operating in a safe and effective manner. We should all aspire to that. I think sadly it's clearly a reflection of the pressures that we talked about earlier, and that if we were working in a GP practice scenario anywhere in the country, but obviously in Lincolnshire, if we had great estates, we were fully staffed, we were well resourced, you would hope, and we would definitely aspire to be having a different set of outcomes. So I think it's a bit of a temperature check on what's happening in terms of the pressures for practices, because an awful lot of work is going in from the ITB. At the LMC, we do an awful lot of work with practices around CQC. What I would say, particularly around CQC, is it is an incredibly complex process for practices. There are so many facets to it. It changes, and obviously the new inspection process, so practices are having to try and adapt to that as well, while of course trying to do all the normal day-to-day things as well. And that's particularly pressured if you are then short of a practice manager or an ops manager or the GP who leads on this example. So we should all aspire to have really good reports, of course, from CQC. It's good for our patients, and actually it's a positive feedback loop for us within practices. But I think, unfortunately, it is partially a reflection on the environment that we're working in currently. And it's particularly difficult if you are then working within a wider system where acute trusts are struggling or the ambulance services are struggling, etc., because we're all part of one big system, aren't we? And we all have a knock-on effect on the others.
You may briefly come back, Councillor Cleaver.
Thank you. Just one thing to pick up on then. The fact that there is a higher proportion of GP practices in Lincolnshire that are rated as requires improvement or inadequate compared to nationally. Would you care to comment on that? Do you think there's any factors that we should be aware of in that?
Thanks. Sarah Jane and Nick may also come in. I think part of it will at least go back to some of the pressures that make Lincolnshire, unique compared to some other areas nationally. Okay, so if we're thinking about that national figure, part of it will be about the inspection processes because they vary a little bit. Part of it will be about the system that those practices are working within, and clearly for Lincolnshire, our infrastructure and our geography actually have an effect on the service that we can provide. So clearly that has, as we've already talked about, an effect on workforce recruitment and retention, which is going to have a direct impact on the report findings. If there is an adverse event that happens within a GP practice. That might be partly something that's happened within the practice, but also might be directly linked to one of our colleagues at one of our trusts, or be that the acute trust or EMAS or anyone like that. So because we are all directly linked and all of our individual organisations are challenged, that might be part of the explanation as to why we have a different percentage to other areas of the country.
Can I just... So I think readers alluded to, obviously Lincolnshire has got very different communities, very different demographics, and if you look at the variation and some of the pressures, they are inextricably linked to some of the challenges, particularly in the rural and coastal communities, and the infrastructure to support patients in those areas. I think it's also just to try and provide a balance, because we are never complacent about the fact that we've got practices that are both either requires improvement or inadequate. And as Nick has talked about, we are consistently supporting them. But the counter is we actually have 90% of our practices who are delivering really good care. And I think, we should never be complacent, and we should always work with the practices and recognise the challenges in those the communities. But I do think it is important to also acknowledge that we have got some really good practice service delivery for patients across the county. And from an ICB perspective, it's really understanding what's, if you like, beneath that variation. And that's where the GP strategy is going to be really important, because my hypothesis is that there will be elements that are about the integration with other services, the facilities in those different communities. I was with a practice yesterday, and they were describing how people living in their community will wait, even though they have a clinical need, and they can access support over the weekend. They will wait because they don't want to travel 20, 30 miles to a service. So we've got all those complexities that, as part of our GP strategy, we will need to look at and consider how we support general practice in those areas.
Okay, thank you. I've now got Councillor Kendrick, please.
Thanks, Chairman. I noticed in the report there's a remark about DNA rates, did not attend, relatively low for Lincolnshire. By coincidence, last week, a patients group in the GP practice in my division approached me because they were concerned about DNA rates. Would I help them publicise the need of people to let surgeries know if they can't turn up for an appointment? I was just wondering what might be done to reduce the DNA rates even further. What support, for example, are you giving to GP practices in terms of publicity to remind patients that if they can't turn up, to let the practice know? Because this practice gave me the data for the first 4 months of this year, which they were concerned about for DNA rates.
Yeah, thank you. We do provide some generic comms to practices, but generally practices will kind of manage that messaging to themselves. And I think something they will often pick up with their patient participation groups too, to kind of support that message and get the word out there. I think we have relatively low, again, don't want to be complacent, we have relatively low DNA rates in Lincolnshire, which is great. I think we're about 3% compared to 4% across Midlands, but still work to be done. We have been doing some work with primary care networks around their enhanced access services and promoting those and making sure information's out there. And again, that patients, if they can't attend, they let the practice and PCNs know, so those appointments don't go to waste if they can't attend. I think there is some further work we can do. Certainly something I can pick up with our comms team and with our PPG co-production group. One of the things we've developed recently is a co-production group with our patient participation group. So we're working with them on the issues that are priorities to them. I'm working kind of in a co-productive way, so working alongside them on that. So again, something I think it'd be worth picking up with them to see what we can do to improve comms to patients around making sure they let practices know if they can't attend.
And just to add, and whilst it isn't a solution, because we know that there is different people have different digital capabilities or preferences, a lot of practices actually now have the capability to send text reminders to patients. And whilst that will not address everybody's problem, actually, if it starts to address some of the problem, then we can better understand how we reach those people who don't have the sort of like digital tools and things. So we've supported practices, and I know, I'm sure Reid will say, a lot of the practices talk about something called AccuRx, and if I was to threaten taking it away, I think I'd have a stampede, because it's become a really useful and very efficient way of directly contacting individuals, and particularly around reminding them of appointments.
Thanks very much. If your comms could do that, promote it in a wider community, because obviously GB practice don't have their comms teams or anything like that. I think that would be helpful to GB practices. Thanks.
Thanks. Just one other small point on that was, I think historically patients have said that they've struggled to cancel appointments in terms of getting in touch with practices on traditional phone lines. Clearly there's been a lot of promotion in Lincolnshire for the NHS app, so people there are able to access that to cancel their appointments, as well as a host of other features. So hopefully that gives a little bit more accessibility and flexibility to do that. We will always have a percentage, of course we will, because someone's ill on the day, but there is good promotion of that. So.
Okay, I've got Councillor Burke next, please.
Thanks, Chair. I'm still coming to grips with these reports as a new member, so if this is a bit random, do work with me. Thanks for the point on the digital issues, which is I'm interested in here. My own surgery, in fact, does text messages. It's really useful, including for those of us who don't think we're digitally challenged but can easily forget things. So on page 36, I'm sort of picking up GP 20% decrease in real terms of GP since 2015, and at the same time GP appointments can be good compared to national averages, but there's that feeling that needs improving, and I think you started to talk about that. And this is the big push on online services, which is good, but how much do you feel the community's needs upskilling, the actual community ability to use digital services? And I appreciate that might not be your job primarily, but are we working with other people, for example, the University of Lincoln? So I'm just interested in that. So across the county, we've had a drop of 101 to 81 GP provision, so a 20% decrease. And I'm interested in, and I know that's been touched on earlier today, I'm wondering how we deal with that, or am I picking up something that's not a big issue, but it feels big. And then from January, we've got the pharmacies thing coming in, haven't we? And I suppose, I mean, I'm very lucky, my local pharmacy, Tilby Street, is excellent, but, you know, I have to ask the question, how do we know pharmacies are up to scratch for this change? So a pharmacy needs assessment, needs to monitor the impact of pharmacy first. I'm asking, do we? And then a colleague indicates to me far outside my area of Lincoln that in Spalding there are queues for pharmacy services. Now I'm not seeing that in Lincoln, but you've talked about rurality quite rightly, and we're a Lincolnshire-based committee, so I am interested. Are there parts of Lincolnshire where the absence of pharmacies, are they an issue? Is Spalding a good example of that? Then on page 39, I was picking up some primary care networks have not used the full allocation due to the recruitment issues which you've already referred to. Is there a risk of burnout to GPs because of overwork? Page 40, I've just randomly mentioned each GP responsible for a further 17% of patients, so that's got to be a concern. And then finally, page 41, 20% of GP practice capacity action through GP surgery instead of hospital. I'm just interested in that. I mean, that could be a positive. Thanks for that.
There's lots there. There was lots there. So I'll try and cover a few things. In terms of the number of GP practices reducing from 101 to 81, that has happened over a period of years, and there are different reasons. On any occasion where we find ourselves in a scenario where there is a possibility that a practice might close, we do a very comprehensive review in terms of what will be the impact and what is the best solution. And we have done different things. So we have dispersed patients to other practices. We have procured different services. And we will continue with that conversation. And I think it is something that is particularly important in a rural and coastal community, because general practice does need to be accessible in the community. That is, where it sits. And so we do need to get the sweet spot in terms of that. We also need to get the right size of practice that makes them, as Reid referenced earlier, financially sustainable and able to cover the complexity of needs. And if you don't have the right economic size, that can put a practice under pressure. And increasingly working with primary care networks can help to support local service delivery. And in relation, linking to that, in relation to the R's, which is the additional, and you're absolutely right, some of our primary care networks weren't able to recruit fully to their allocation. There has been a change in the rules. So the rules with regards to recruiting to the R's roles were very, very prescriptive. There were only certain roles that you could recruit to, and that was specified. And if you weren't able to recruit those professions, then you were constrained. That's changed this year, and PCNs can put forward other roles to be included in the for funding, provided they are patient-facing. So there's certainly some PCNs who are looking at a more, I suppose, a broader skill mix and a broader professional framework that reflects their local population. In terms of GPs, I'll probably let Reid comment on that, but I think it does reflect some of the points that were made earlier in terms of the changing profile of GPs moving away from being partners to increasingly being salaried. And as you introduce new roles, so the R's roles, those roles will need appropriate supervision, and often that falls to the GP partners. So again, it's quite a complicated picture of a journey, I think, towards a different model of general practice. And then just linking back, as part of that different model in terms of accessing primary care and accessing the type of support, there is a very robust framework in terms of making sure that community pharmacists have the competence to do the work that they're being commissioned to do. In terms of whether we have enough community pharmacists across Lincolnshire, I think there are areas of the county where I would say we would benefit from having more community pharmacy, and that links back to the point that Nick was making earlier, that we can't look at the general practice strategy without understanding the need to develop the wider primary care offer. And so we'll also be looking at a community pharmacy strategy. We've already got a dental strategy, and at some point we'll also be looking at optometry, because it's the full picture that gives you the wider community access to primary care, not just general practice. I'm sure.
Thanks, Chair. Firstly, thank you for your questions, and clearly you've read my report really thoroughly, so luckily so have I, so I'll try my best. Obviously, Sarah James has given some great answers about some of those elements, but I'll just take them very briefly if that's okay. I say briefly, but I tend to waffle, so I apologise. Just your first point about digital provision or training. Yes, we do. We need more training and upskilling for our population. However, naturally, we are seeing a trend to people being generally more digitally literate. Oh, just said it. Obviously, access to robust IT infrastructure and devices is a barrier to that. But what I've said before, probably at this committee, is I'm quite often astounded by some of my patients who you may incorrectly assume might not be able to access it, are brilliant at navigating it and really value it. But there is work to be done, most definitely, and I think we want that both locally and nationally. So in terms of practices closing, I think I just want to be really clear here. Yes, it happens for a number of different reasons, but no GP partner wants their practice to close. They are so proud of what they do, despite all the challenges. We don't want them to close. So when it closes, it's heartbreaking for them. Financially, they can face bankruptcy. They've got to obviously make people redundant. That's their risk as well. And then we've already talked about the risk to patients in terms of the domino effect onto other local practices. So we should be avoiding that at all costs. What does that need? Going back to my earlier point, we need more resource, more funding, more support, and more interlinking of services so a patient can get a nice holistic end-to-end treatment pathway. And the GP practice is thriving in the middle of that, because that's what we all want to go to, our GP practices at the end of the day in our village or local town. Pharmacy first, yeah, I mean, we've had a lot, I talked about it in the report, we've had a lot of conversations with our colleagues in community pharmacy. I think they were keen for a new challenge, but they already had really busy day jobs. Their pharmacies were already really, really busy. Their colleagues were working really, really hard, just like we are in general practice. And the risk of bringing in a new service is, does that deflect them away without a huge uptick in their workforce from the core things they're doing day to day? Now, when I've been talking to my colleagues in community pharmacy, they were quite surprised by the number of patients that contact me on a Monday that could be diverted into community pharmacy. I think we don't really quite understand the volume yet, and the data still to be seen, of A, how much activity there is, but also the potential activity that could go through these services. And obviously, again, community pharmacy have difficulties with their own estates and infrastructure, which would need support to roll this out on scale. I haven't heard about the queues, but I can imagine they're very busy on a Monday morning and every other morning like GP practices are. But it's just, again, maybe a temperature check on the amount of demand and resource that's needed to support patients across the county, not just in general practice, but community pharmacy and the other elements of primary care. In terms of your PCNRs, so they are highly valuable colleagues. I have some great R staff members in my practice. Really, really enjoy having them. The patients generally love them now. They've got to understand a little bit more about what the R's offerings are. But again, as an LMC, what we want is core general practice staff. We want GPs, and most patients still see the GP as the person they want to see. Clearly, nationally, the landscape has changed because of the recruitment issues, and these staff are integral to a lot of practices now. There is a little bit more flexibility, perhaps, with ours roles that can be brought in, but we still can't bring in GPs, for example, which is what patients might expect. Supervision is a growing, escalating pressure on GPs to provide that, because when you bring in more R staff, you're quite right, they need supervision. Some of these people have never worked before in primary care, or particularly in general practice. They've got to start from the basics of how it works day to day. They've got the medical knowledge, but they need that support. And ultimately, if they're working in our practice, we are responsible if something goes wrong, so we have to be making sure we're supervising them. If I am the sole partner in my practice on a particular day, I might have 2 or 3 R's members of staff that I need to supervise. Ideally, I need to look at every consultation they're doing. I need to talk to them. I need to give them a bit of training. It can easily take several hours a day of my time, which you could say I could be seeing patients directly myself instead. But they need that support, and this is part of the MDT team we've got. MDT team we've got within Lincolnshire now and again nationally. Does it risk burnout? I think when you have so many elements, there's only so many hours of the day. If I'm in my practice, I'm doing 12 or 13 hours, and then I'm going home and I'm doing some more, and I'm doing it at the weekend, I'm doing it on days that I'm not meant to be working. But that's what we've got to do to cover all the bases. And yes, that work potentially takes us away from seeing patients ourselves directly. But that's currently where we are now. 17% more patients per GP, is that a risk? Yes, it is. The data, it's quite clear that as you increase the number of patients per GP, patients don't feel they get as robust a service, and the outcomes may change for the negative for patients. That again is a national direction of travel. We need to stop that. Going back to my earlier point, how do we stop that? Working conditions, resource infrastructure, etc. I think the thing about the 20% of workload within general practice being between primary and secondary care, obviously I've said earlier we're looking at that. Releasing that would be really, really good for many reasons. If that's 20% of GP capacity, what could we do with that 20%? It also would reduce delays for patients and hopefully enhance the patient journey, because if a patient expects something to be done in general practice that would have ideally been done in the hospital, and then we say we can't do that for some reason, it's frustration on a patient basis. It's going to be a delay for them. Hopefully there's not a negative outcome for them as a result, but it would just make patients happier, and actually we'd feel more fulfilled getting that all done straight off the bat. One of the key things within that, which I alluded to in my report, was understanding between colleagues. So we've had 3 events recently over the last couple of months with GP practices and GPs and practice managers attending meetings with our secondary care colleagues. And what I have to say, it was refreshing, the things we didn't know about each other. And when you don't understand what someone is contracted or commissioned to do, what they can do, what tests and investigations they have access to, what support services and integrated services they can link directly into, you have a very different perception of what's happening when you come out of that meeting to when you went into it. And I think particularly for our secondary care colleagues, they were astounded by the pressures in general practice, and were astounded by the things we aren't commissioned to do that sometimes we are doing. And there's got to be a bit of give there. Something's got to change. So I think the understanding will help, because it will also help the patient journey. I've meandered on for quite some time. I'll stop there.
Thank you. I've still got 5 speakers so far that have indicated, so I'm going to close the debate down from there, because I'm conscious of what the time is now. So I've got Councillor Pessell first, please.
Thank you, Chairman. As we've seen that there's an increased focus on tertiary, triage operations in surgeries to ensure that the maximum amount of GP face-to-face appointments are optimised. My only concern with that, and I speak as someone who is a chronic user of GP services, so I've first-hand experience of this. I'm concerned at the level of training that is being given to PCAs in terms of their signposting capability and their ability to recognise, specifically with those with chronic conditions where flare-ups may not be obvious, and what are the safeguards to ensure that they are signposting correctly, and what are the sort of monitoring standards that are covering that, just to ensure that people aren't being misdirected when they're phoning up for a potentially serious condition that may not have an obvious presentation. Secondly, in regard to just coming back to pharmacies, the new pharmacy programme is welcome. It's my understanding, though, that it's currently a voluntary process. What has been the uptake of pharmacies for these new roles, and how even is it across the county? Particularly, my concern is that it may be below average, say in rural areas where they're already swamped with business as it is.
Thank you for the question. I'll pick up the pharmacy question first, if I may. In terms of pharmacy sign-up to Pharmacy First, we've got good sign-up across the county. I think we've got 94% of all community pharmacies have signed up to it. The one pharmacy that hasn't signed up to it is a distance pharmacy, so they kind of deal online with prescription requests, etc. But we have good spread. I think there are issues in terms of pharmacy access across the county, which we've alluded to earlier, so I won't go into that. So I think some, particularly communities in rural areas on the coast, etc., may find that they have less access to a pharmacy just because of geography and where pharmacies are placed. Something, again, that will be looked at through the pharmacy strategy and pharmacy needs assessment. So yeah, generally though, with Pharmacy First, good uptake across the county. In terms of triage and safety netting, I think Reid may want to come in from a clinical point of view, but hopefully I'm not putting him in the frame for that. But in terms of that triage, I think practices do have safety netting procedures, so they will review triage processes. Just for information, we are working with a couple of practices who are looking at their triage process currently, and what they're doing is putting their most senior experienced GP managing that triage process. So they have one GP who's kind of assigned to that over the day. That looks like a really positive model so far. It's early days on that, but we're working with one PCN and another practice around that model. What that also seems to do, as well as making sure you've got a really experienced clinician triaging patients and making sure they're getting to see the right clinicians or referred onto the right services, it's also helping with demand as well, because they can deal with these queries much more quickly, and they can keep things like the online Ask My GP systems open for longer. So really just just to flag some of the work we're doing to support practices around that. But generally speaking, I think practices will have safety netting mechanisms in place to make sure that their staff are triaging people appropriately and getting them through to the right service.
Thanks, Chair. Thanks for your question. I'll not go on to the pharmacy bit because I think it's already been covered there. Yeah, in terms of the triage, I mean, triage is crucial now. We can't operate in general practice without triage due to the demands that patients want appointments for various staff groups across general practice. Just to point that into context, so apologies Sarah Jane and Nick, they've heard this not too recently from myself. When I joined my practice 10 years ago, I've looked back at the data, and we've essentially nearly doubled our clinical capacity over 10 years, and our activity levels have gone up 5-fold. We can only do that activity level because of triage. Now, if we went back to an old model of just book an appointment, come and see me, sit in front of me, we'll talk about whatever they want to talk about for 10 minutes, and then do that, we soon come back to a point where access is really going to suffer for patients. So triage is crucial. Now, I think there was a time when a lot of practices varied what they did, and sometimes it was non-clinical people doing the triage, but I think what we've seen across Lincolnshire is, as alluded to, having a clinical person do that triage, usually a senior clinical person, actually helps with the process. Clearly, the opposite of that is if I'm triaging as a senior clinician in my practice, I am not seeing the patients, I am triaging them, which goes back to the earlier discussion points we're having. So there are pros and cons to doing it. If there is signposting going on within practices from non-clinical staff, there's been quite a bit of training around care navigation and signposting for non-clinical staff in general practice, and particularly things around like Pharmacy First, as we just talked about. There are quite strict criteria for who is eligible for that, and for example, if someone calls up with a sore throat, then the reception member is signposting in that particular practice. They put in the clinical details of the patient at the time, and the software that's used tells them, actually, this doesn't seem like it's going to be suitable for Pharmacy First, needs to be dealt with in the GP practice. There's an internal safety mechanism there. If something does go wrong, and unfortunately with the volumes of patients that we deal with in general practice, and just like in A&E and just like in the hospitals, sometimes the bad things happen. We don't want them to do, but practices all have an internal significant events process where if something happens, if somebody is misnavigated, for example, and that comes to harm, the practice will then look at that and see if there's anything that needs to change within their processes to negate that happening in the future. It's really difficult with the volumes of people that we are dealing with in general practice, but there are lots of mechanisms.
Okay, thank you. I've got Councillor Wotton next, please.
Thank you, Chairman. Thank you for the report. I'm referring to Appendix A, page 39. If you could explain this paragraph to me, please. I'll read it out. It says the recently announced GP contract 24-25 included 1.4 billion for staff recruitment, but this is not for core general practice staff such as GPs and practice nurses. And if areas are unable to recruit using this funding, it states it will be lost from the Lincolnshire system. Now, if it isn't for what it states, what is it for? And do we really want to lose £1.4 billion if we can access it? And whilst I'm on this page, my pet A is acronyms. Could you explain to me what ARRS is, please? And also, one more quick one, Chairman. It states that a GP can safely see between 20 or make between 25 and 28 contacts in a day, and in some cases GPs are making 37 contacts. Would this just be using the telephone as well as you've seen your patients personally? If you can explain that to me. Thank you. Thank you, Chairman.
So if I'll answer the first question about the 1.4 billion, then I'll pass to Reid. So the 1.4 billion actually relates to the additional roles recruitment scheme, which is what ours stands for, which are the posts that we were describing earlier, which are complementary roles, so physios, community clinical pharmacists, social prescribing. So there was a whole sort of like spectrum of different roles, but it didn't include GPs or practice nurses. Going forward, there is opportunities for the primary care networks to put forward other roles that they might want to recruit that weren't in the previous list, but it still won't include GPs and practice nurses. I think that's correct.
Yeah, thank you. In terms of 37 contacts, obviously this is data that's been researched at a national level, so and European level. So contacts usually in people's minds is talking about telephone calls, video calls, face-to-face appointments. Okay, but the activity that goes on in general practice, the vast majority, almost exclusively, everything we do requires a clinical thought process. So even if I'm asked to re-prescribe a certain drug for a patient, I might not be sat in front of them, I might not be on the phone to them, but I have to make a clinical judgment, look at them as an individual, look at their other medications, and use my clinical experience to decide whether that's an appropriate thing to do. There's a whole plethora of decisions we make every single day, and we sign lots of electronic prescriptions, physical prescriptions, we look at hospital letters, we look at the blood results that have come through. They all need clinical work. So the 25, 28 or 37 contacts today per day, as alluded to on that report, most people think of as telephone or face-to-face appointments. But then we have this whole plethora of work that goes on in the background, as I said in the report, that goes into several hundred a day when you look at the prescriptions, the bloods, the letters, etc., that we process. We still think that those numbers are a significant underestimate because we know we still don't capture all the data, not just in Lincolnshire, but nationally. Hopefully that answers your question.
I've got Councillor Smith next, please.
Thank you, Chairman. I find this report quite difficult, and I am reminded very fondly of Councillor Mike Thompson, Dr. Councillor Mike Thompson, when he was a member of this committee. And there are a number of things in it, Chairman, that, I'll be blunt, they deeply concern me. For example, when you get to the bottom of page 60 in the report, what it basically says, Chairman, and I am trying to shorten my comments because I know that you have closed the debate down, that basically to grow the NHS workforce in terms of general practice, more taxpayer money is needed. Well, Chairman, I'll be blunt, that really isn't an option. Money doesn't grow on trees, and to be blunt, the NHS allocation as a whole, and I'm not referring to GP practices, we've already heard how their funding is different, but as a whole, the department has been protected for 4 years. Local government has not. we are responsible for adult social care, Chairman. As you know, if we fall and we are struggling, nobody can sit in here and deny we aren't struggling. The NHS is going to have a world of pain on its hands if we suddenly go, well, we can't deal with adult social care anymore, you're going to have to deal with it. So for them to say, we need more money, please, to be blunt, Chairman, get in line, so do we, so do we, and so does everybody else. That isn't an option. That you have to become a bit clever with how you box and how you use the money you are allocated. And I think that has got to go into general practice and how the workforce is grown. I absolutely take Dr. Baker's point around the pressure you are under. I see it just trying to get an appointment for myself and people, you know, residents come to me. I know the pressure you are all under, and I absolutely take that on board. I will briefly go back to a point you made, Dr. Baker, around the old system of you would say, can I come see you, and the impact that have, which is obvious. But to patients, in an ideal world, that is the system they want, because that would mean, well, I'm working today, for example, so I go to the GP and say, when have you got an appointment? I can't see you today. They would then say, oh, I've got one 2 days later. Right, okay, I can sort work out and I can come and attend. Most working people, especially if you're working shifts early in the morning or late at night, you simply don't have that option, Chairman. So what you actually end up finding is more patients will end up in A&E or will end up in secondary care because they simply are not able to, even with certain late hour openings, they're simply not able to access a GP with other commitments in their daily life. The other thing that deeply alarms me, Chairman, in the report is the cost of doing something as simple as taking blood is a detriment to GP practices. That, quite frankly, Chairman, that's actually terrifying to me when I read that, is what on earth is going on when a simple thing of somebody taking blood is costing hundreds of thousands to GP practices, and it's not money that they can recoup. And I know that's not a question necessarily for Dr. Baker or Sarah Jane or anybody else. That's a question of very senior commissioners at very high levels within the National Health Service of how GPs are funded. I actually had the conversation with Dr. Mike Thompson when he was a councillor around, is the current model of how GP practices function workable? And I think that is actually a conversation we all need to have with each other, because, as has already been said, a lot of GPs now, they don't want to be partners, they want to be salaried. So is the current system actually workable? Because eventually you may get to a point, Chairman, where you'll have plenty of salaried GPs, but nobody wants to be the partner, nobody wants to take on the role of running that business as is. And if we get to that stage, Chairman, that conversation is going to happen whether it's wanted or not. So we're far better to have that conversation in advance of time rather than having it forced. The only other thing I would like to add, Chairman, is my final point with your indulgence, around numbers. Part of the problem around practice numbers is, and I know it's not something we deal with here, but it's the planning system, Chairman. I had it recently in West Lindsey. The local GP practice said, we are full, we have nowhere to expand the surgery, we can't expand. NHSE, oh, everything's hunky-dory, you can take those patients. And as sitting on planning as I was, we have to go with what NHSE say because they are the statutory consultee. And to be blunt, Chairman, the two need to get round a table, and NHSE need a protocol where they actually listen to the GP practice who are on the ground and dealing with that. And when the GP practice says, no, we can't take any more, NHSE should listen to that as a statutory consultee and go to planning and say, doesn't matter how much money you give us, they can't take any more. Because the next thing that will happen to that practice, Chairman, in Welton, and other practices, but I use Welton because that's the example, is that practice will close its list. So then you have a situation of they will have to go into Lincoln, which there, as you will know, Chairman, their practices are already high in number anyway, as I'm sure Councillor Burt will know far better than me, being a local member. Then you get the domino effect. Then they will shut their list, and they will shut the list. And you will then potentially get to a point, Chairman, where it's happened in other areas in the not-too-distant past, we have to close because the numbers are unsafe. So then you put an entire practice on somebody else. So there needs to be a serious conversation, Chairman, around how that functions, but also around how GPs as a business work, because I don't think the current model is workable, because more and more GPs want to be salaried, they don't want to be partners, and we need a serious conversation around how the NHS funds GPs generally because when they are having concerns of doing something as simple as a blood test, Chairman, that is deeply disturbing, and there needs to be that conversation, because obviously the status quo is not sustainable. But it's not practical, Chairman, to say, can we have more money, please, when the NHS as a whole over the last period, notwithstanding the inflation that we've all been through, Chairman, we've all suffered it. We've suffered it here. We've, as a county, individuals, our residents have suffered it. We can't keep going back saying, can we have more, can we have more? Because there isn't more to go around, Chairman. That's the fact. So we have to work with what we've got, and there needs to be that conversation. And I think that's not necessarily something for here, but it's something we take away and work with each other, because the status quo just isn't workable. Thank you, Chairman.
I think you raise a number of really, really significant points, all of which are part of if I can call it, a national conversation in terms of whether the funding framework is the right, whether the business model is the right model. The estate readers referenced a number of times about the challenges with regards to having the correct infrastructure to support practices. And I know we're coming back in July, so I won't talk about the relationship with the Section 106, but there is a lot of planning and discussions, and then there are challenges in terms of accessing capital funding for primary care estate, which is of course different to then the challenges with regards to revenue funding, and I would concur with your observation about there is a finite amount of funding available, and constantly colleagues across the NHS and colleagues in primary care are looking at ways to operate in an innovative way that utilises that funding and meets patient need against a backdrop of growing patient need. And I'll just refer you back to Reid's point about if we didn't now have triage in place, that actually we just would not be able to do it, and the level of resource that would be required would be unachievable. But all of the issues you raise are a national issue which we feed into, but obviously have limited local control.
Thanks, Chair. Thanks for your points. I'll cover some of them due to time. In terms of investment, so we're quite right. There's two potential options. Well, there's three, isn't there? The status quo that we have now, and I don't think that's viable. We know in the UK we have one of the lowest GDP investments into the NHS of any major European or G8 country, and that's both just in terms of gross investment and capital investment as well, and diagnostics. So we are already behind the starting gun compared to some of our other compatriots across the globe. So we can invest more if we to bring ourselves up to those levels, but clearly that's not a comfortable decision to make at a national level, but might help to remedy some of the issues we have. The other option is investing what we do have differently. And obviously that's part of the conversation and part of the discussion within the report about shifting resource, be that people and funding out into the community where patients like primarily to see their local team to get their care done. So that really needs to move along, and the resourcing needs to follow, because a lot of work has moved into the communities, but the resource infrastructure, etc., to support that and make it viable hasn't yet. I agree completely with you about things like phlebotomy. We shouldn't be operating any services that are at a loss to general practice, because again, risking the viability, risking that to the patients, as you eloquently allude to, but also patients, again, they expect those services to be available, and most of our patients would not realise that that's what happens. And if we were to stop doing some of those services, would also give the patients a really negative perception of their practice without realising the method behind why that decision is being made. I take on board your point about GP practice being full and housing development still happening. We understand clearly we need a lot more housing, but again exacerbates the pressures not just on GP practice but schools and every other part of the infrastructure. Does the current model work at the moment? I think all the research shows that the current partnership model is the most financially viable for national system. We know if we move to a salaried GP model, we need a lot more GPs, and they aren't there at the moment. And one thing that, and again, I think I've said this before in committee, I don't know what any of you do beyond seeing you today and talking to you and listening to you. The amount of work that goes on behind the scenes from GP partners is huge. One of the biggest risks is losing that. What will that do to any service that we provide? But I take on board all your points.
I'm very conscious of time, so incredibly briefly.
Thank you, Chairman, for your indulgence. Dr. Baker, you may not know the answer to this, but is there a way you could, or we could find out, Chairman, what is the cost to the system as a whole for those that, for whatever reason, be it work, be it other issues, who are unable to then access a GP when they need to at that level at that moment, who then end up in A&E in another system? What is the actual cost? Because I don't know the answer to that, Chairman, what the cost is to Lincolnshire, but I should imagine it's a lot. And I use my own experience. It was during COVID, I couldn't see a GP for 6 months. When I eventually saw one, it was, well, Mr. Smith, you need to now go and see A&E. And don't get me wrong, the GP was fantastic. I can't fault them, they were absolutely brilliant. But I was very aware and thinking, oh dear, this is going to cost a fortune, because I've now had one ultrasound, several X-rays to tell me something I suspected it was, and it wasn't. You know, that's not cheap. When in the ideal world it would have been see the GP. I appreciate time was very different because it was COVID. See the GP, bang, that's the problem. There you are. There's your solution. Now I can see my next patient. So it's what do you think the cost is as a whole? And thank you for the reply into the partnership model. That's very helpful that you've explained that, so I appreciate that. Thank you.
Probably my brief answer is no, we don't have that data. We don't have a mechanism to capture it. And I think there would be nuances around how you would capture that data in terms of patient perception of what the journey has been. But clearly it would be useful to know that, because that would obviously show us what system cost is there. And so, yeah, we don't currently. But maybe that's work to be done. I'm not sure how we would begin that.
Thank you. What I will say, if I remember rightly from some time ago, Dr. Hindosha once said that just turning up to accident and emergency would cost £400 roughly. So it is substantially higher. I've got Councillor Morgan, please.
Thank you. First of all, I'd just like to say I totally agree in the sense that I think for me what stands out overall with this report is that basically we're on the edge of not being sustainable. What particularly concerns me on page 36 is that we're being told that triage was introduced, and when you look at the time frame in which the benefits of that have been wiped out by increased patient demand, I find that really alarming, because there's some point where how much more can our GPs physically do. I want to say, just to balance things a bit, I think it's absolutely remarkable the amount of work that our GPs do. Millions, I mean, we're talking over 4 million patients have been seen. That was just in 1 year. That's staggering. My mother actually used to work for GP as a nanny. This was before the NHS was introduced, and she actually recalls a story where somebody came knocking on her GP's door, asking for help, a patient, their father was dying, and the GP turned around and said, "I'm sorry, I'm going to the theatre." And thank God those days have gone. And we have a fantastic NHS scheme where millions of people are being seen for free, and I think it's something that we should be treasuring. I think it's a political decision, we've touched on it, whether we continue to fund it properly. There is money. According to the Equality Trust, £113 billion every year.
Can we get to a question, please, Councillor Morgan?
Yeah, well, waited all this time. I'm just answering that point. I think it's really important. £113 billion is leaking out of our country every year. It needs 36 billion to address the majority of the issues within our NHS. I think it's about priorities. I'm interested, I want to pick up on the planning point actually. I also have a real concern about that. And is there anything we can do about this? We've got an application just going through the pipeline at the moment. I'm Vice Chair Planning at South Stephen.
That's coming in June, that particular item. Anything around planning, we've already said that that's a June issue, so.
Oh, okay, I just want to make this point though, because it's in this report that we are basically looking at £165 a year patient. Well, that's one site is actually allocating per new patient £212. That will cover only one GP for 1 year. There's clearly a shortfall in what we're asking for in relation to development, and that isn't sustainable either, and is going to put even more pressure on our services. I think the other area I'm concerned about, and I'd like your feedback, is what impact poor quality housing and poverty are having on you. I know from my own experience...
No, sorry, I'm going to stop it there. It's not about housing and quality. We're here to discuss what is actually being put in front of us, and so I'm going to stop it at that point. Thank you, Councillor Morgan. We've already said that we're having property coming forwards. This isn't a planning committee meeting.
I was going to ask about mould, actually, and the impact that's having on respiratory conditions and how that's affecting visits to the two GPs.
All right, I think that question's now been asked. Thank you.
So in terms of the planning, as Councillor Macy has said, we're coming back in and we will do a full item. But just to clarify, there is a difference between the capital funding, which is what you'll be referring to, and the revenue funding, but we'll explain all of that. In terms of the broader issues with regards to housing, general practice is part of the integrated care system, and so of course there is, and I'm sure Reid will be able to clarify, of course there is a consequence of people living in poor housing on their health, but that is why increasingly we operate as an integrated care system and work together, and general practice is one part of that. There are other people who then we work with to support the discussions around how they look at improving housing. So I think those are the 2 points that I would make.
Thank you. Okay, I've got Councillor Mackinson-Saunders next, please.
Thank you. There's a bit of a thread running all through this, isn't there? Coastal and people not being able to access services. I know in the town where I live, there's a lot of dissatisfaction with GPs, and the urgent treatment centre is bearing the brunt of that, and that is really, really busy as a result of the lack of GPs, really, and that's and they're brilliant at the UTC, but we're going to come to that next month. I was going to make a general point about funding, because if we can't afford blood tests and we can't afford this, that and the other, we have 40,000 caravans on the coast in the summer, that increases the population. Professor, I think he's called Professor Hurry, is he, at Lincoln University, who does rural health, has actually, he's come up with lots of facts and figures. People are presenting later because they can't see GPs, and so basically it's costing the health service more money. And it all goes back to, why aren't we fighting more for fairer funding? Because fairer funding for Lincolnshire we should all be holding up banners for that. And I'm going to have to say this, but there's never been a better time to shout about fairer funding whilst we have a health minister who is in this area. And fairer funding is just vital for Lincolnshire. And it's unfair on our residents if they don't have it. So I wondered what we could do in here to fight for fairer funding to raise that a bit higher up the agenda. Thank you.
Yeah, I think it's fair to say that the County Council has always fought for fairer funding, and I think obviously has spoken to all of the districts across and other colleagues, and yeah, absolutely, and of course we're probably likely to have a new government of one way, shape or form going forward, so I think that'll be the time to again push for better and fairer funding across. So, but I think it's definitely something that all councils should be readdressing and certainly going for. And I think it's something that our NHS colleagues, of course, need to get on side with and support us to push through, because we can all see the issue, and we do know that Lincolnshire is probably one of the worst funded in the country. So, you know, I think...
and certainly there's a department at Lincoln University which is looking at rural health, etc. And they should be standard bearers for us, shouldn't they?
Thank you, Councillor Mackinson-Saunders. I've no further speakers. I just have a couple of questions myself, which I'll get through fairly quickly. So on page 48, the final paragraph of section 4, the report states the LMC and others have raised concerns in regard to GP contract financial uplift. To date, has there been any response to this? And how likely do you think it will be to see an acceptable level of rise in the funding?
So yes, it's been raised nationally by not only Lincolnshire LMC, but every LMC and most GPs that, as we talked about the referendum across the country. How likely is it to change? I am not overly optimistic. As you may have heard, the GPC England, when they were in negotiations with NHS England, asked for 8.7 or 8.9% uplift, which was just have restored us to 1920 levels, you know, because of inflationary rises. They put very compelling arguments together. The data was all there. They'd done lots of surveys across all practices about costs and activity, etc. And yet we were left with the 2%. It is not convenient and potentially not, as we talked about, resourceable to increase that in general practice. It is vitally needed, that and more, to do the things we would all aspire to do. So national discussions are ongoing, and as a result of the referendum, over the next few months, there will be further discussions about what may need to happen, what discussions may need to be moved forward as a result of that.
And then there have been reports in the national media that GP locums now finding it difficult to find jobs. One of the reasons cited in these reports is the expansion of the additional roles in GP practice. Is this an issue in Lincolnshire?
Thanks, I'll take that one as well. Yes, it is. So I speak to locum colleagues who are struggling to get work now through different organisations that they would historically have not struggled to get work through. So while we've expanded our roles colleagues, and clearly that's a national scheme that is reimbursed, however, some PCNs and practices are having to top up some of those pay scales for those R's roles colleagues as well, to try and retain them so they can help patients. It has had some effect on locum colleagues locally. The other issue is that as a result of the financial constraints within practices maybe can't fund or afford to support, to bring in locum colleagues that they might have traditionally done. So it's kind of a double whammy for those locum colleagues. They are obviously looking for alternative ways of getting employment, particularly if they already have channels or practices they routinely go to.
Thank you. And then my final question, the primary care people plan includes a table on page 67 of the agenda pack which suggests workforce share were nearly 50% of admin. Can you explain these figures? Sorry, Sarah Jane, would you mind putting your microphone on? It's just that people listening in won't hear.
Are these the ICB staff? This is the ICB staff rather than the general practice. Can I take it away when I can see it properly, and I'll come back to. I'm like this.
I think Nick's going to try and pick up.
Yeah, no, I think that those are GP practice staff, and how they're categorised. I think the admin staff are basically non-clinical, non-patient care staff within GP practices. So that's the data across the region for different ICBs. Sorry, could you repeat
Yes,
the question,
certainly. As I was saying, it suggests workforce shares were nearly 50% admin in those practices. So could you explain that?
Yeah, I think that's just the standard GP. I mean, again, Reid may want to comment from a GP practice point of view, but those are sort of fairly standard across the region in terms of the staff roles within practices. So that would include admin staff, telephonists, receptionists, etc. But I don't know, Reid, if you wanted to comment.
Yeah, I'll come in and comment. So again, I guess it's a bit like I was saying earlier. You're not quite sure what goes on unless you do a role. I think there's an increasing amount of administration and non-clinical activity that goes on in practices. Be that organising some of the new initiatives and services that are launched, liaising with the PCNs and doing some of the work that they do, and also the practices have obviously had traditional feedback that it's been patients have found it challenging to get through on telephone lines, etc. So where possible, practices have brought on more administrative staff to man telephones and more secretarial support, etc. And again, it might be a reflection that if you focus your clinical staff on certain roles that they can focus on and do, that you might bring in non-clinical staff to do some of the other things that we might have done traditionally. And again, that's just about recruitment and retention.
Sure.
Just very briefly, actually, in terms of planning this year, we did look at workforce and it's a forecast, but one of the things we are expected to see change over the next 12 months is a slight reduction in the percentage of admin staff and an increase in clinical staff. I think it's relatively small, but I think that recognises some of the digital systems we're putting in place which support telephone access, etc. That's just a forecast, so it's something we will be monitoring over this year, and it'll be something that the primary care people group will be looking at closely.
Okay, thank you. In which case I'm going to move to a proposal. And firstly, I'd like to thank our presenters for sharing information on GP provision in Lincolnshire. Secondly, welcome the progress made in the GP provision, including the increase in the number of appointments in GP practices over the last 5 years and the associated hard work that's gone into this, and to seek a further update on GP provision after a period of 6 months. Do I have a seconder for my proposal? Thank you, Councillor Mackinson-Sanders. All those in favour, please show. Thank you. That's supported unanimously. And once again, thank you to our presenters. Free to go, so thank you. We'll move on to agenda item 7, the protocol between Health Scrutiny Committee and NHS Lincolnshire's ICB. This item was circulated as part of the agenda pack on pages 79 to 90, and I'd like to hand this over to Simon Evans, our Health Scrutiny Officer.
Thank you, Chairman. Just to just for the benefit of people who've not been here throughout this process, back in January, the Secretary of State issued new guidance and regulations were approved in Parliament for health scrutiny committees and also for integrated care boards, which changed the, if you like, the landscape that the health scrutiny committees operate. So one of the things that changed was that it's no longer possible for health scrutiny committees to make referrals to the Secretary of State, and also a power of ministerial intervention was introduced, whereby an individual any one of us as an individual could make a request to the Secretary of State to call in a proposal for change within the NHS. Now that's subject to certain hoops, some of those hoops quite small, I think, but anyway, it's subject to a number of hoops that people would have to jump through in order to get a request to be live, as it were, or made valid. So as a result of this, we basically needed to rip up the previous protocol and start more or less with a blank sheet of paper. And that's what has been going on in the last couple of months. I think I apologise. I think I originally suggested this would be on the March meeting, but it did take, perhaps, anyway, yeah, longer than maybe I thought. But it has involved various colleagues. Derek Ward, for example, was involved in reviewing the draft. Also colleagues at the ICB. So this is brought to the committee today for the committee's consideration and approval. I think the key sections I would highlight on pages 84 and 85 are, those are the big numbers at the bottom, are the basically the factors that the committee would perhaps consider in making a decision whether an NHS proposal is substantial, and those are the factors. I would stress that this is not in any way going to become an administrative process done by me or anyone else sitting in a room somewhere. All the items would still come to the committee, and it would then be the committee's decision with reference to these, if you like, factors, whether in its view a proposal was substantial. So that really is the basis of the new protocol. The ministerial intervention powers are set out on pages 87 and on pages 87 and 80, just on to 88. But that's there for the committee, and hopefully as a protocol it should stand up in its own right and not need explanation. Thank you, Chairman.
Thank you. Before I open it for any questions, I'd just like to thank Simon and Pete Burnett and Derek Ward and everyone else that was involved with this process. I know a lot of work has gone into this, and I think we're making the best of the situation that's now in front of us with the legislation. So thank you to those. Councillor Mackinson-Saunders.
Thank you, and it's really sensible, but a lot of us look out of out of Lincolnshire, and this just talks about Lincolnshire. A lot of us go, we have no choice. The ambulance takes you where they want to go or where they're told to go, and so it does include neighbouring authorities as well, and I just wanted to make sure that we are covered by that as well.
Specifically, I'll bring Simon in, but I don't think we are. We cover our geographical area, I'll put my teeth in, and ours only. I think the reality is that the other health scrutiny committees and ICBs will have to come up with their own protocol. I would say they can't really go too far differently from what we have, but who knows? But I'll bring Simon in.
The situation when we go outside Lincolnshire is slightly more complicated, because in those circumstances where it is cross-border, the regulations are quite strict in saying you have to have a joint committee, which we are aware has existed. Well, I suppose it continues to exist with the joint Humber and Lincolnshire Joint Health Scrutiny Committee, which has been looking at the proposals for Scunthorpe General Hospital in particular, which clearly affects Lincolnshire patients. So yes, there is a limitation. It is only Lincolnshire and proposals that are brought forward in this county. Where it is a wider scheme, that's when I have to be vigilant. Members of the committee maybe have to be vigilant if there is a proposal outside Lincolnshire which is going to lead to a significant change. Thank you.
Councillor Smith.
Thank you, Chairman. This question, I appreciate that it's very much new ground we're covering, and I'd also like to echo your points that you've made on the work that's been done on this protocol. This question may be a bit out of left field, but I think it's important. Do we have a rough idea what happens procedurally in the event of a request to dissolve a trust or ICB, and what role the Health Scrutiny Committee would have in respect to oversight in determining any possible harms to residents, if we have any role at all?
I will with pleasure pass you over to my learned friend.
No, I didn't expect that question, but that's specifically written out of the regulations. I don't think it would necessarily preclude the committee from getting involved, because I think the committee has previously become involved in things that perhaps, if you read the letter of the regulations and guidance, it may not necessarily need to get involved in, but certainly that would be the case, that if there was a proposal. I mean, we've been told several times that the group arrangement with ULHT and LCHS is not leading to a merger, but maybe at some point they will be looking for a merger, and that would be something I'm sure they want to run past this committee in any event, irrespective of what it says in the, in the detail of the regulations, although it wouldn't fall under the substantial criteria as a change in service, patient-facing service. I don't know if that's helpful or.
It is helpful. So I know it's outside the regulations. That's sort of why I ask, because they're not particularly helpfully worded, Chairman. I'll be gentle, which is not your fault. That is Simon, and I'm not suggesting otherwise. It is a national issue with how the legislation has been drafted, which is why I asked the question. Because obviously, although it's not patient-facing, that has major, I mean, you can imagine, so, and purely hypothetical, ULHT says, oh, we're going to dissolve. The implications on patient-based services as a result would be huge, would be massive. And I appreciate you probably can't answer the question now, Simon, which is sort of why I asked. But if there is any information we could dig up, Chairman, it'd be, if there is anything, and there probably isn't, but if there is, it'd be very helpful, because obviously, I know it's a what if, but we don't know what 2-3 years is going to happen, as we found out with the joint review, the Humber Joint Review, Chairman, and as we've already said, we suspect we'll be back there in a couple of years as well. So better to be forewarned and forearmed.
The only thing I would say with this is that whilst there have been a number of changes with NHS reconfigurations, one of the things that seem to be the enduring elements of this are that the provider trusts, so ULHT has been around for this century, probably I think it was 1999 maybe, and certainly LPFT for the same amount of time. I know LCHS is much shorter because it was only created in around 2011-12 when it was the provider arm of the old, I think it was PCT in those days. So, but they seem to be, and during this time we've had PCTs, well, primary care groups, then PCTs, then CCGs, and now, so the commissioning side seems to change more often than the provider side. But I still think, I mean, it wouldn't necessarily, you know, there could be a number of things that might happen with the trusts being dissolved. It might be split into two, or merged with another trust, as, you know, North West Anglia was created with Hinchinbrook Hospital coming under the wing of what was Peterborough and Stamford Foundation Trust at that point, and then became North West Anglia. So these mergers do occasionally take place, but they're less frequent than it does seem to be less frequent changes on the provider side compared to the commissioner side. Thank you.
Thank you. I think I'd say that, as with anything that's new legislatively wise, that will be open to challenge. I would have thought at some point, not necessarily ours, but, and I think Pete Burnett did indicate there are some challenges happening nationally now where they're looking at where this new protocol is in place, actually how much of it stands, how does it work. So time will tell. Councillor Cleaver.
Thank you. Just coming back to the point about health services for the people of Lincolnshire that aren't commissioned through our ICB, and also to respond to the role of the committee and how it fits in with NHS Lincolnshire ICB. Just to go back to our constitution, in LCD's constitution, and it very clearly states in one bullet point that our role is to review and scrutinise any matters relating to the planning, provision and operation of health services which affect the residents of Lincolnshire, except those that are under the remit of Adult Committee and Children Committee. It then further says, further down, which I mean it's interesting to see, is to make reports and recommendations to any relevant NHS body, to any relevant health service provider, the County Council, the Executive or relevant Executive Council, in relation to any of the committee's functions listed above. So I don't want us to get into a mindset where this protocol, we feel that it's constraining what we can do. What we can do is what I've just read out. So the point being that when it comes to scrutinising anything that Lincolnshire ICB and making recommendations on anything that Lincolnshire ICB does, we can do it anyway.
No, it's certainly not constraining what the committee can look at. I think the real intention of the protocol is on consultation, so that there is a framework, and it is, I mean, in a sense, it is really about those factors that the committee is being asked to look at when there is a change in service. So we are aware of previous changes where there has been consultation, and we've all got some in the back of our mind, and we may have some in our minds which might be coming up in future. And one of those may be on the list for July, possibly. But yes, I think it doesn't constrain. So whenever the Lincolnshire ICB is, if you like, commissioning services, as it does from external, so the Lincolnshire ICB provides Northern Lincolnshire and Goole with a certain amount of funding for its services. Similarly, North West Anglia gets funding. It can certainly review and scrutinise those services. I think the consultation on changes, which is what this is about, that is really where, once you go over the border, it then now becomes quite complicated in that there does seem to be a need for a joint committee. And if you actually read the regulations, you can't actually get round it. You can't just say, oh...
We have tried.
Yeah, you can't, I'm afraid, no.
And that's the frustration, I think, here, really, that they can subsume almost where we are. But that being said, the new legislation would still allow you, so say that something is going on across the border, you could still basically use the new way of raising an issue there. But you're just not statutory anymore because it will subsume into that committee. And that's the reality where the legislation has changed. Anything further? Okay, so for now, I take it we're happy to progress with this. I'm happy to propose it. Do I have a seconder? Councillor Woodson. All in favour, please show. Thank you. Yep, that's supported. In which case, we'll now move on to agenda item 8, the work programme. You'll find this on pages 91 to 102. And back over to Simon.
Thank you, Chairman. So, page 92, three main items listed for the 12th of June. Urgent Treatment Centre strategy from Lincolnshire. And the reason that Grantham Urgent Treatment Centre is listed separately is that that's not being included in the strategy because that has only been open since November. So there is a separate update on the first sort of 6 months or so of operations at that centre. So that's why that is split, although I may be repeating myself there. The suicide prevention strategy is something that the committee considered, I think, back in February 2023, and is something that the committee recorded its interest in seeing when it was revised. Just moving on, I've already hinted in the last item that there may be something coming forward where there may be a change, and I think it could be number 2 on the list for the 17th of July, which is the pilot dementia home treatment team, which has been running as a pilot for at least a year, probably 18 months, maybe even 2 years, but certainly that is funded by the closure of the Manthorpe ward at Grantham Hospital. So there has been I think there was an email late yesterday afternoon, saying that there is engagement beginning with patients on this. And I've been asked to list this as an item for July. So I think this could be the first example where we're actually using the protocol. Anyway, we'll, I'd say I won't go on about all the other items. Time is short, but if there are any other questions or suggestions, I'll take those. Thank you.
Councillor Cleaver.
Sorry, just quickly. On item 1 for 12th of June, could I suggest that should be worded Lincolnshire Urgent Treatment Strategy, so it covers all urgent treatment across the county and not just that takes place in centres. Sorry to be pedantic.
I think the specific thing is about the urgent treatment centres rather than it is about, we were told in the autumn of last year that the urgent treatment centres were being reviewed in Lincolnshire. Now that word can have all sorts of connotations, but I think there may be some concerns that it may lead to changes in opening hours for certain urgent treatment centres And I think that's why the word is urgent treatment centre rather than a broader item on urgent care. But one of the things I think we will be asking, I know that, I don't know if Councillor Cleaver is sort of thinking about the Stamford Minor Injuries Unit, because I think that would have to be included in, and sorry if I'm second guessing what you're asking, but I think that would have to be included because the terminology minor injuries unit is something that NHS England no longer accepts or likes. So something in a way has to be done in Stamford with that unit.
Yeah, because I think even the UTCs are now grade something A&E anyway. It's literally just new terminology and it all falls out of place. So yeah, I would imagine the UTC would fall in there, well, even though it's not an official UTC and what they will be doing. But we will ask that question in fairness coming forwards. But obviously, as Simon's alluded to, Grantham's a completely separate issue and it isn't been part of the review, but everywhere else has been as far as we're aware.
Yeah, thank you for that. And can I have a conversation with you offline about item 1 for 17th of July, about the scope of that, because that could be quite interesting.
Any other questions or anything else? No, Councillor Burke, sorry, yep, I did have you down, sorry.
No, it's all right. It's just a quick admin for me as a new member. And by the way, since the 5 years ago I was here, can I just compliment this committee on how much more detail you're now covering than you did before, and more challenging to some professionals. First of all, who's Nick? Because he's fallen over.
Nick Blake.
Thank you. And secondly, just to help me, when are the papers published? And by the way, they were very easy to find online, so thank you for that. When should I go looking for these papers? Oh, you sent me a copy as well.
And it's always exactly a week before, well, it's the Tuesday, really.
Very good. Thank you very much.
No problem. Thank you and welcome back. Anything further then, in which case? No. So we're all happy with the work programme moving forward. That brings the meeting to a close. Thank you all very much for your attendance. Thank you.